Good morning, everyone. I hope the audio and the visual is okay. Just show me a thumbs up, beta, if audio and visual both are fine. Good morning to all of you. Good morning. Tell me, beta, just tell me whether the audio and visual are fine. I hope the audio and Yes, thank you so much. So, on Sunday morning, all of you getting up at 5:30 and now it's 6 to attend this session. I'm so proud of all of you. Right, as I have written over here, this is a very nice quote which I read and I get motivated, so I thought I'll share this with you all. Some people dream of success while others get up in the morning and make it happen. I'm so proud of my bachas who have got up and are going to make this happen. Right, it takes a lot of strength to get out of your bed, number one, and then on a Sunday morning to be there to attend a session, and that too such a beautiful morning it is. Right, so it's it's like so such a proud feeling that all of you are not just seeing dreams but are ready to work hard to make your dreams come true, right? So chalo, let's continue with Gynae part 3. In Gynae part 1 and 2, I had covered in-depth revision of the cancers and contraception, and now we are going to complete the rest of the entire Gynae. Like you would have understood beta by now, that entire Gynae can be divided into 4 parts when it comes to questions. First of all, you are going to get questions from cancers. Then you get questions from contraception. And then you get questions from primary amenorrhea, secondary amenorrhea, DSTs, and then rest everything comes. Right? So let us talk about prolapse. This was a question which had come in your exams. This is a PYQ, and based on this, we are going to start with prolapse. A 55-year-old lady presents with third degree uterine prolapse. Which of the following is the best management for her? Now, you are going to tell me, first of all, let's talk about Fothergill's repair. The age of the lady which is given to you is 55 years. Please understand that when we are talking about prolapse, it can be a uterocervical prolapse or it can be a vaginal prolapse, right? Now, the management of uterocervical prolapse, it depends on the age and parity of the patient. But the management of vaginal prolapse, right, it doesn't depend on age and parity. There is a single management for the vaginal prolapse, right? It doesn't depend on what is the age of the patient. It doesn't depend what is the parity of the patient. Management is same for vaginal prolapse across all age groups, right? So if we are talking about vaginal prolapse, that was a question related to uterocervical prolapse. When we talk about vaginal prolapse, in vaginal prolapse, we can have a cystocele or a urethrocoele. How do you manage a cystocele or a urethrocoele? What is the surgery which is used for managing cystocele or urethrocoele? Who's going to tell me the surgery for managing cystocele or urethrocoele? It's anterior colporrhaphy. Anterior colporrhaphy, right? How do you manage a rectocele? If they say a rectocele or if it comes laxed perineum, whether it is a rectocele, whether it is laxed perineum, how do you manage it? You manage it with a surgery which is called as posterior colpoperineorrhaphy. Posterior colpoperineorrhaphy, right? Now, understand that anterior colpoperineorrhaphy and posterior colpoperineorrhaphy together are called as pelvic floor repair. Pelvic floor repair. Now, how do you manage an enterocele? What is the management of enterocele? Who's going to tell me how to manage an enterocele? Tell, how are you going to manage an enterocele? What is the surgery? Quickly, I'm waiting for you in the chat box. What is the surgery for managing enterocele? जल्दी बताओ. Very, very important surgery, named surgeries. These surgeries are extremely important. बताओ. MECCAL, excellent. It's MECCAL caldoplasty. Right, the outdated surgeries are Halban repair and Moskowitz repair. Right, but we do MECCAL caldoplasty. Please remember, MECCAL caldoplasty is both prophylactic and it is therapeutic. So why do we say that it is prophylactic? Whenever a question comes to you where your answer is vaginal hysterectomy, whenever we are doing vaginal hysterectomy, it increases the chances of enterocele. After vaginal hysterectomy, the chances of enterocele become high. And that is why, to prevent enterocele from happening, whenever we do vaginal hysterectomy, we should be doing a MECCAL caldoplasty, right? Okay. Now, this is about vaginal prolapse and its management, right? Now coming to uterocervical prolapse. Now when it comes to uterocervical prolapse, the new classification for uterocervical prolapse is the POPQ classification, that is pelvic organ prolapse quantification classification. In this POPQ classification, what is the reference point? The reference point is hymen. Reference point is hymen. So over here I have drawn the hymen. Now how do you stage uterocervical prolapse with respect to hymen? Now if the prolapsed part is within 1 centimeter of hymen, which could be +1, that is 1 centimeters above hymen or 1 centimeters below hymen. So if it is within 1 centimeters of hymen, then that is stage 2. Right? So 1 centimeters proximal to hymen or within 1 centimeters distal to hymen, that is stage 2. If it is more than 1 centimeters above hymen, then stage 1. If it is more than 1 centimeters below hymen, stage 3. And prosidentia is when the entire uterus and cervix are out. Have you understood? The reference point is hymen. If the prolapsed part is within 1 centimeters of hymen, either 1 centimeters above or below, then that is stage 2. More than 1 centimeters above hymen, stage 1. More than 1 centimeters below hymen, stage 3. And then we have prosidentia. So this is the new classification for prolapse, which is called as the POPQ classification, right? Now, in uterocervical prolapse, the management depends on the age and the parity of the patient, right? So, if your patient is reproductive age female, right? So, if your patient is a reproductive age female, or if she wants future childbearing, and she wants future childbearing. So, any female who's reproductive age and wants future childbearing, the surgery which you do for prolapse in such patients is called as sling surgery. Now, in sling surgery, we can have anterior sling or we can have posterior sling, right? Anterior sling. Anterior sling का example क्या होता है? Anterior sling का example होता है पुरंदरे sling. Purandare sling, right? And posterior sling ka example, the example of posterior sling is Shirotkar sling. Now, in Shirotkar sling, the complications are more, right? And these complications, but the success rate is also more. Whereas in Purandare sling, the complications are less and the success rate is also less. Now, in case of Shirotkar sling, you have to remember that the complications are more special, or not on the right side, but on the left side. Complications are more, especially when you are passing the sling through the left side, right? And when you are passing the sling through the left side, while the sling is coming from the uterus back to the sacral promontory, in Shirotkar sling, on one side the sling is attached to the isthmus of the uterus. On the other side, the sling is attached to sacral promontory. So when you are taking the sling from sacral promontory to the isthmus of the uterus, on right side, no problem. But when you are bringing it back from the isthmus to the sacral promontory on left side, there is a problem because we have the colon over there. So this sling can press over the colon and that can lead to intestinal obstruction. And that is why whenever you are doing Shirodkar sling, you are going to make a hook, right? So you make a hook so that the pressure doesn't come on the colon. And this hook is made of psoas muscle, right? This hook is made from on psoas muscle. So these are the points which you have to remember about sling surgery. Now, remember just one more thing, that there is something which is called as composite sling or Virkud sling. Virkud sling. In composite sling, on left side I am going to do Purandare and on right side I will be doing Shirodkar. Because the complication of Shirodkar was on right side, so on, of the complication of Shirodkar was on the left side. So on left side I am replacing Shirodkar with Purandare, whereas on right side I am doing only Shirodkar. So right side pe Shirodkar kar lo, left side pe do Purandare. That is what is called as composite sling or Virkud sling, right? Okay. Now, this is if your patient is reproductive age female and she wants future childbearing. Now, if your patient is reproductive age female, but she does not want future childbearing, she does not want future childbearing, then we go for Fothergill's repair, right? The other name for Fothergill's repair is Manchester surgery. In Fothergill's repair or Manchester surgery, there are two important steps. One step is the plication of cardinal ligament. CL is cardinal ligament. Plication of cardinal ligament. You all know that cardinal ligaments are attached on the sides of the uterus. Posteriorly, there is uterosacral and anteriorly, there is pubocervical. Pubocervical ligament is a weak ligament, right? So what we do is, the cardinal ligaments which were attached to the sides of the uterus, we remove them from the sides and we tie it to the anterior side of the uterus. When you tie cardinal ligament to the anterior side, anteriorly you have a very strong ligament now, that is cardinal ligament. Posteriorly you have a very strong ligament, that is uterosacral ligament, and that is going to prevent prolapse. So number one is plication of cardinal ligament, and number two is amputation of cervix. So these are two important steps in Fothergill's repair. Fothergill's repair cannot be done in females who want future childbearing because of this step, that is amputation of cervix. When you amputate the cervix, there are high chances that it can lead to cervical incompetence, which in future can lead to recurrent second trimester abortions. It can lead to cervical stenosis. It can lead to cervical dystocias, right? So because of the step of amputation of cervix, you cannot go for Fothergill's repair in females who want future childbearing. This is when a female wants future childbearing. Please remember that the most common age group for prolapse is menopausal female. Most common age for prolapse is menopausal females, and prolapse is more common in multiparous females. So menopausal multiparous females are the most common age group for prolapse. So if your question comes that a female is she is a menopausal female, and she has got prolapse, now I am going to go for vaginal hysterectomy, right? Now, whenever you are doing vaginal hysterectomy, and if along with the third degree prolapse, if your patient has got cystocele and rectocele, so if a menopausal female has third degree prolapse plus she has a cystocele and a rectocele, I will say that I am going to do vaginal hysterectomy plus I am going to do pelvic floor repair. Now, whenever you do vaginal hysterectomy along with pelvic floor repair, it is called as Ward-Mayo's hysterectomy. It is called as Ward-Mayow's hysterectomy. So whenever you are doing vaginal hysterectomy plus pelvic floor repair, I'll just write it properly so that you people can read it. Pelvic floor repair. Then that is called as Ward-Mayow's hysterectomy. Clear to all of you? Right. Now suppose your question says that there is a postmenopausal female, right? But she has comorbidities. Now, if she is a postmenopausal female with comorbidities, the anesthetist will not give me consent to give anesthesia, and without anesthesia, I can't perform the vaginal hysterectomy. In that case, I am going to do Lefort's colpoclysis. Lefort's colpoclysis. Right? Now, if your question says that the elderly female is more than equal to 65 years, right? If your patient is more than equal to 65 years, in that case, I don't even want to do a Lefort's colpoclysis. In that case, I am going to use a ring pessary. Use a ring pessary. For all those who have not attended my classes, I am just telling you what is the purpose of ring pessary. See, when do we say it's a prolapse? Uterocervical prolapse ka matlab hai, suppose this is the uterus and cervix and my hands are vagina. Uterocervical prolapse ka matlab hai, the uterus and cervix are coming out of vagina and hanging like this. Now suppose I have something, right? I have a space occupying object. For example, suppose this is a ring pessary. It's a space occupying object, right? Suppose this is a ring pessary and I have put this ring pessary in vagina like this. Now when I put a ring pessary in vagina, uterus and cervix cannot come down because this ring pessary will not allow the uterus and cervix to come down, and that is the principle behind using a ring pessary. Clear to all of you? Right? So whenever your patient is more than 65 years of age, you are going to use a ring pessary. Similarly, if prolapse is happening in a pregnant female or it is happening in a postpartum female, you are going to use a ring pessary. Now, if they ask you what is the best method to prevent prolapse, when the question comes best method to prevent prolapse, you are going to say it's Kegel's exercises. Kegel's exercises. What is not a support of the uterus? Tell me which ligament does not support the uterus. It is broad ligament. Broad ligament is the best answer to this question will be broad ligament. If broad ligament is given, you are going to mark that as the answer. But if broad ligament is not given, then the second best answer is round ligament. Why? Because round ligament is a secondary support of the uterus. If you have to choose between broad ligament and round ligament, always choose broad ligament as the answer, that it is not a support of the uterus. Broad ligament diya hai, then there is no confusion. You have to mark the answer as broad ligament. But if broad ligament is not given, then you are going to mark the answer as round ligament. Now, if a question is asked that which ligament helps to keep the uterus in anteverted position? Which ligament helps to keep the uterus in anteverted position? Again, it is round ligament. Two questions about round ligament other than that it helps to keep the uterus in anteverted position is round ligament is homologous to gubernaculum in males. Right? That is one very important point. Second very important point is round ligament is supplied by Sampson artery. Sampson artery is a branch of uterine artery. So round ligament is homologous to which structure in males? Gubernaculum. It's homologous to gubernaculum in males. So these are all important points which you have to remember about round ligament. Now, the other very important question. If question comes, which ligament helps to prevent retroversion? Which ligament helps to prevent retroversion? The answer to this question should be, tell me, which ligament helps to prevent retroversion? All those who have attended my class in Marrow or DBMCI, you know the answer to this question. Tell me, which ligament helps to prevent retroversion? Quickly, it is uterosacral ligament. If uterosacral ligament is not given, then you are going to mark the answer as round ligament. But the best answer to prevent retroversion is uterosacral ligament. Best answer to keep the uterus in anteverted position is round ligament, right? Now, sometimes they ask, you see a decubitus ulcer on a prolapse, and they ask you what is the reason for the decubitus ulcer on the prolapse. So what is the reason for a decubitus ulcer on prolapse? The reason for a decubitus ulcer on prolapse is venous congestion. This ulcer is seen because of venous congestion, right? Now, what is the management of decubitus ulcer? How do you manage a decubitus ulcer? Management of decubitus ulcer is by doing glycerine plus acriflavin packing. Glycerine plus acriflavin packing. Glycerine is a hygroscopic agent and acriflavin is an antiseptic, right? So I am going to go for glycerine and acriflavin packing. So these are questions which they can ask you on prolapse. The other very important point in prolapse is something which is called as walled prolapse. Now, what do you understand by walled prolapse? Walled prolapse is the prolapse which occurs once the hysterectomy is done. After hysterectomy, the part of vagina which is left, we all know that when we do hysterectomy, we remove uterus and cervix. Vagina is not removed. So if the vaginal apex, it prolapses after hysterectomy, that is what is called as walled prolapse. Now they ask you, what is the surgery for walled prolapse? Now the simplest surgery for walled prolapse is a vaginal surgery which is called as uterosacral suspension. In uterosacral suspension, so if this is the uterus and the cervix which has been removed, and this is the vaginal stump which is left after doing hysterectomy. So once I have done hysterectomy, these uterosacral ligaments which were initially attached to the uterus, अब uterus को तो निकाल दिया during hysterectomy, तो in uterosacral ligaments को I will attach it to the vagina, right? So the stump of vagina, so that the vault does not prolapse. And this surgery is called as uterosacral suspension. Now, if you are a good gynecologist, you are going to do this before vault prolapse happens whenever you are doing vaginal hysterectomy. So, whenever we do vaginal hysterectomy, the complications we know in future can be vault prolapse and enterocele. So, a good gynecologist will, along with vaginal hysterectomy, she will always do uterosacral suspension to prevent vault prolapse, and she is going to do mechalcaldoplasty to prevent enterocele formation. So uterosacral suspension is both prophylactic and therapeutic. And it is a simple surgery to perform. But this is not the best surgery. What is the best surgery? Best surgery is sacral colpopexy. What do you do in sacral colpopexy? 1 second. Best surgery is sacral colpopexy, which is an abdominal surgery. In sacral colpopexy, like you attach a mesh when you repair hernia, you are using a mesh. Similarly, we are going to use a mesh which on one side which will be attached to the uterus, and on the other side it is going to be attached to the vault, right? That is what is called as sacral colpopexy, where I am using a mesh, right? Now, there are certain named surgeries which you should be knowing, because once in your exam they had asked about this, that the named surgeries, and there was a match the column kind of a thing. So you should also know the surgeries for SUI. What is SUI? SUI is stress urinary incontinence. That is, whenever there is passage of urine, involuntary passage of urine, whenever intra-abdominal pressure is increased. On increase in intra-abdominal pressure. Intra-abdominal pressure. For example, during laughing, during coughing, right? So whenever there is involuntary passage of urine on increase of intra-abdominal pressure, like during laughing, like during coughing, that is what is called as SUI, right? So see this question which was asked in Neet PG 2021. A 56-year-old multipara woman presented with grade 2 or grade 3 uterine prolapse and cystocele. She complains of passing urine on coughing and sneezing. What type of urinary incontinence is seen in this patient? So what type of urinary incontinence is seen in this patient? This is what is called as stress urinary incontinence. Now, SUIs may you just need to know about some of the surgeries. So what is the most commonly done surgery in SUI? The most commonly done surgery is TOT followed by TVT. What is TOT? TOT is tension-free trans-obturator tape. And what is TVT? That is tension-free trans-vaginal tape. Right? So TOT is the most commonly done, followed by TVT. In TVT, there are some complications. In TVT, you enter the retropubic space. You have to enter the retropubic space, and that is why injury can happen to all the structures which are present in retropubic space. The important point about both these surgeries are that both these surgeries are vaginal surgeries. In both these surgeries, they are daycare surgeries. And in both these surgeries, it is the middle part of urethra which is suspended. Please understand that why does SUI happen? SUI happens because the bladder neck descends down. That is the most important reason for SUI. So SUI happens. What is the reason for SUI? It is bladder neck descent. So common sense tells me that if the bladder neck is descending down, whenever I have to manage SUI, I just have to lift it up, right? So in whatever surgery I am doing for SUI, my aim is to lift the bladder neck up. Right? Now, in order to lift the bladder neck up and to keep it suspended, I will have to suspend it to some structure. Now, whenever I am doing TOT and TVT, which are vaginal surgeries, which are daycare surgeries, I am going to suspend the middle urethra. Middle urethra is suspended. Right? Now, when it comes to the best surgery for SUI is Bursch-Kolpo suspension. Bursch-Kolpo suspension. Bursch-Kolpo suspension is the best surgery. It's an abdominal surgery. In this case, the proximal urethra is suspended. The proximal part of urethra is suspended. And to which structure it is suspended? It is suspended to Cooper's ligament. What is the other name for Cooper's ligament? The other name is iliopectineal ligament. Right? So, this is the best surgery, but you reserve it only if the vaginal surgeries fail. So either you call it as best surgery or the gold standard surgery. Right? There was one more surgery which was abdominal surgery where the proximal urethra was suspended, but it has been outdated. What is the outdated surgery? Outdated surgery is MMK surgery. Who is going to tell me the full form of MMK surgery? What is the MMK surgery? What is the full form? Marshall, Marchetti, Krantz surgery. Right? Again, this is abdominal surgery. Right? Again, over here, the proximal urethra is suspended. and the proximal urethra was suspended to the pubic symphysis. Now, because it was suspended to pubic symphysis, that is why the complication which happened was osteitis pubis. And that is why this surgery is no longer done. Right? Now, coming to what surgery is done for vesicovaginal fistula. Names of the surgeries are very, very important. What surgery is done for vesicovaginal fistula? Latsko repair. Right? Or Chaser-Moyer surgery. Chaser-Moyer surgery. Right? Then, what is the name of the surgery which is done for septate uterus? For septate uterus, now what surgery are you doing? Excellent. I can see Archita, you have written rightly, ma'am. MMK is Marshall Marchetti Cran surgery. Now tell me, for septate uterus, what surgery do you do nowadays? For septate uterus, the surgery which you do is, tell me quickly, who's going to tell me? Septate uterus ki surgery, what surgery is done for septate uterus? Who's going to tell quickly? I'm waiting for you in the chat box. It's hysteroscopic septal resection. Hysteroscopic resection of septa. Right? What is the outdated surgery? What is the outdated surgery? John's metroplasty. John's metroplasty, that was the outdated surgery. What is the indication for doing surgery in case of septate uterus? When do you do surgery in a septate uterus? So whenever there are Mullerian malformations, you have to do surgery only and only if it leads to recurrent abortions. If it leads to recurrent abortions, then only you are going to do surgery for septate uterus or surgery for Mullerian malformations, right? Now, for bicornuate uterus, what is the surgery which you do? For bicornuate uterus, what surgery? Nowadays, we are doing the repair, like we are doing metroplasties, right? Metroplasty. What is the name of metroplasty? Thompkins metroplasty. Thompkins metroplasty. Right? Okay. Now they asked you, once a question had come in your exam, that what are the important points after surgical repair of VVF? Thompkins metroplasty and Strassman, both are there. Excellent. Thank you for reminding me that. Strassman and Thompkins metroplasty, both are there. Right? Okay. Now, what are the important points after surgical repair of VVF? This was a question which was asked in your exam. So post-operatively, what instructions are you going to give? Number one, you have to do continuous bladder drainage and you have to give antibiotics for 2 weeks. Then you have to tell her this 2 weeks is very, very important. Then you have to tell her that she has to maintain abstinence. There has to be no per speculum examination, no per vaginal examination for 3 months. Minimum 3 months and ideally 6 months. So for 3 to 6 months, it has to be no per speculum examination, no per vaginal examination and no intercourse. And pregnancy is contraindicated for 1 year. So these are the things which have to be remembered post-operatively. Continuous bladder drainage with the help of Foley's catheterization and antibiotics for 2 weeks. No per speculum examination, no per vaginal examination and abstinence for 3 months. Minimum 3 months. Ideally 6 months, and pregnancy is contraindicated for 1 year. Please remember, if a patient conceives after VVF repair, then you have to do cesarean section for future pregnancies, right? Coming to urinary fistulas. All of you know that there can be three types of urinary fistulas. There can be a fistula connecting urethra to vagina. That is what is called as urethrovaginal fistula. Then there can be a fistula which is connecting the bladder to vagina. That is vesicovaginal fistula. And there can be a fistula which is connecting the ureter to vagina. That is ureterovaginal fistula. Now in all these three cases, the history of the patient is going to tell you that what type of fistula it is. Suppose if a patient is saying that she is having continuous dribbling of urine from her vagina, but she is also having normal urination. This means that it is a ureterovaginal fistula. Whenever there will be a ureterovaginal fistula, whatever urine is coming from this ureter via the fistula is going to come out of vagina. So that is why she will complain of continuous dribbling of urine from her vagina. But whatever urine is present in the other ureter is going to fill the bladder, and that is why she will also have normal urination. So if your patient is saying that she has continuous dribbling of urine from vagina and she has normal bladder emptying also, that means it is a case of ureterovaginal fistula. On the other hand, if she is saying that she is having continuous dribbling of urine from her vagina, but there is no normal urination. Now, whenever there is a vesicovaginal fistula, that means the bladder is connected to vagina. No matter which ureter is bringing urine, whether it is left or right, ultimately it has to come into the bladder, and it is this bladder which is connected via fistula to the vagina. That means she will have continuous dribbling of urine from her vagina. But because her bladder is connected to vagina, her bladder will never be full, and that is why she is going to say that she has continuous dribbling of urine from vagina, but she never has normal bladder emptying. She will never have a normal sense of urination. That means it's a vesicovaginal fistula. When it comes to ureterovaginal fistula, urethra is always empty, right? It does not contain urine, right? So patient will never say that she has continuous dribbling of urine from vagina. In urethra, urine comes only at the time of urination. So your patient is going to say that she doesn't have continuous dribbling of urine from vagina, but when she sits for urination, urine comes from vagina and urethra. That means we are talking about ureterovaginal fistula. Important points about ureteric injury. What is the most common site of ureteric injury? Most common site of ureteric injury is 2 centimeters lateral to internal os, which is called as water under bridge. What is the second most common site? Second most common site is the pelvic brim. In which hysterectomy is there maximum risk of ureteric injury? Maximum risk of ureteric injury is with Wertheim's hysterectomy, right? And what is the most commonly ureteric injury seen with? Most commonly ureteric injury is seen with total abdominal hysterectomy or simple hysterectomy, because this is the most common hysterectomy performed. Although maximum risk is with Wertheim's hysterectomy is done only in cancer patients. So it's not the most common hysterectomy performed. For all benign reasons, we are doing simple hysterectomy. So the most commonly ureteric injury is seen with simple hysterectomy. Now, in case of fistulas, we have to do the methylene blue 3 swab test. In methylene blue 3 swab test, you are putting 3 cotton swabs in vagina, right? Now, and you are putting a blue colored dye with the help of Foley's catheter inside the bladder and inside urethra. Now, in methylene blue 3 swab test, if you are seeing that the uppermost cotton swab is wet with urine but it is not stained blue in color, that means it is ureterovaginal fistula, because we have not put the dye in kidney. So whatever urine is coming from the kidneys via this ureter is going to enter into this fistula and is going to make the uppermost cotton swab wet. But this will not be blue in color because the dye was not put in the kidneys, right? So if the uppermost cotton swab is wet and it is not stained blue in color, that means you are dealing with ureterovaginal fistula. Now, if the middle cotton swab is wet and blue in color, that means you are dealing with vesicovaginal fistula. And if lowermost cotton swab is blue and wet, that means you are dealing with urethrovaginal fistula. Right? So this is methylene blue 3 swab test. Clear to all of you? About VVF, I told you that the surgery for repair of VVF is Latsko repair or a Chaser-Boyer technique, right? And I have also told you the post-operative complications of the post-operative instructions which you have to give whenever you repair a VVF. Next question they can ask you is, what is the most common cause of VVF in developing countries? So the most common cause of VVF in developing countries, that is obstructed labor. That's the most common cause of repair, the most common cause of VVF in developing countries, right? Now, then in your Neet PG 2020, they had asked what are the remnants of Wolffian duct are present in. Please remember, remnants of Wolffian duct. Wolffian duct is also called as mesonephric duct. So remnants of Wolffian duct in females are epophoron, paraephoron and Gartner's duct. And where are they present? Acha, so Ananya is asking, cyclical hematuria is seen in which fistula? Okay, please understand, Ananya. If suppose there is a fistula which is connecting uterus to bladder. Now, if a fistula is connecting uterus to bladder, I don't expect the urine, right? I don't expect urine to go up like this and come out. What I expect is that when this female is menstruating, blood from the uterus is going to come into the bladder, and that is what is going to lead to cyclical hematuria. So when do you get cyclical hematuria? Whenever a fistula is connecting the bladder to the uterus, that is uterovesical fistula, which is also called as vesicouterine fistula. Right? There are only 2 conditions where you get cyclical hematuria in entire gynae. Either it has to be a fistula connecting bladder to vagina to uterus, or it can be bladder endometriosis. This complaint you will also get if you are getting endometriosis of the bladder, right? So in bladder endometriosis. So cyclical hematuria is seen in 2 conditions, bladder endometriosis and a uterovesical fistula, right? Or a vesicouterine fistula. It's one and the same thing. Clear? Yes. So Ananya, is it clear to you? Okay. Now, coming to the question which I was telling you, we all know that remnants of Wolffian duct in females are epophoron, paraephoron and Gartner's duct, right? Now please understand, Wolffian duct is the one which is going to regress in females. It's the Mullerian duct. Mullerian duct in females is going to form the female internal genital organs, right? What are the female internal genital organs which are formed by Mullerian duct? The fallopian tube, uterus, cervix and upper vagina. Now tell me, in females, from where does the ovary originate? Ovary originates from genital ridge, right? And lower vagina, from which structure does lower vagina originate? Lower vagina originates from urogenital sinus. Which part of the urogenital sinus? The sinovaginal bulb. So if the answer is given as sinovaginal bulb, that is a better answer. So sinovaginal bulb of the uterovaginal sinus is the one which leads to formation of lower vagina, right? The Wolffian duct, which is also called as mesonephric duct, is going to regress in females and it is going to form epophoron, paraephoron and Gartner's duct. All these 3 structures are present in broad ligament. Please remember, Gartner's duct is present in the anterolateral wall of vagina. Gartner's duct is present in the anterolateral wall of vagina. Now, in case of males, in males, Wolffian duct is going to form the internal genital organs. And what are the internal genital organs which are formed by Wolffian duct in males? SEED. Seminal vesicles, epididymis, ejaculatory duct and vas deferens. So these are the organs which are formed by Wolffian duct in males. In males, it is the Mullerian duct which is going to regress, and Mullerian duct is going to form prostatic utricle and appendix of testes. So the remnants of Mullerian duct in males are prostatic utricle and appendix of testes. Appendix of testes is also called as hydatid of Morgagni. Right? Now, other name for Wolffian duct is mesonephric duct. Other name for Mullerian duct is paramesonephric duct. Please remember, M and M are not together. Wolffian duct is not called as mesonephric duct. It is called as paramesonephric duct. Mullerian duct is not called as mesonephric duct. It is called as paramesonephric duct. Wolffian duct is called as mesonephric duct. Right? Now coming to puberty. Now, what is the age of puberty in females? The age of puberty in females is 10.5 years. Age of puberty in males is 11.5 years. What is the first sign of puberty in females? Now, when it comes to first sign of puberty in females, please remember it is growth spurt. Growth spurt, if it is given, that is the best answer. If growth spurt is not given, then you are going to say thelarchy or breast budding. Thelarchy or breast budding, right? Now, if they ask you the most specific sign of puberty in females, the most specific sign of puberty in females is thelarchy. But the first sign of puberty in females is growth spurt. What is the first sign of puberty in males? Testicular enlargement. Testicular enlargement, right? Now, when do you call it as precocious puberty? What is precocious puberty? Precocious puberty is if puberty is seen in females less than 8 years of age. And when do you call it as precocious menarche or precocious menstruation? Precocious menstruation or precocious menstruation. Precocious menstruation is when menarche happens at less than 10 years of age. Then that is called as precocious menstruation, right? Clear to all of you? So when menarche happens at less than 10 years, that is precocious menstruation. I'm just writing it properly. Okay? Okay. Now, whenever a female comes to you with precocious menstruation or precocious puberty, what are the investigations which you are going to do? Please remember that the most common cause of precocious puberty is idiopathic. But before you say that it is idiopathic, remember 10% cases may it is due to brain tumors like hematomas. So whenever I have got a female who comes to me with precocious puberty, I am going to do a brain CT number 1. I am going to actually see what is the age by doing a bone age estimation. Then hypothyroidism can also lead to precocious puberty, and that is why I am going to check her TSH values, and in order to know whether I am dealing with peripheral precocious puberty or whether I am dealing with central precocious puberty, I am going to do her LH, FSH and estrogen levels. In central precocious puberty, LH, FSH and estrogen, all of them are high because central precocious puberty is due to activation, premature activation of HPO axis. There is premature activation of HPO axis. So LH will be high, FSH will be high, estrogen will be high. Whereas peripheral precocious puberty is not because of premature activation of HPO axis. Peripheral precocious puberty is because of some other source of estrogen. And whenever there will be some other source of estrogen, estrogen levels will be high. But because estrogen is high, there will be a negative feedback on LH and FSH. So LH will be decreased and FSH will be decreased. So in order to know whether I am dealing with peripheral precocious puberty or central precocious puberty, I have to do LH, FSH and estrogen levels, right? So these are the investigations which you are going to do whenever a female comes to you with precocious puberty. Now, what is the drug of choice for treating precocious puberty? The drug of choice for treating precocious puberty is continuous GnRH. Right? Now, when a female attains puberty, estrogen is the one which is responsible for breast development and estrogen is the one which is responsible for closure of epiphysis. The main hormone responsible for pubertal changes in a female are estrogen. But even though estrogen is responsible for breast development, in females also for pubic hair development and axillary hair development, which hormone is required? Androgens are required. So for pubic hair and axillary hair, it is a brain MRI or a brain CT. Anything you can do. Better is a brain MRI. Thank you so much for pointing out. Right? It's a brain MRI, not a brain CT. You have to see soft tissue lesion, so it has to be a brain MRI. Thank you for pointing out, Manish. Right. Now, coming to amenorrheas and DSDs. This was a question which was asked in Neet PG 2020. Which of the following is not an estrogen dependent pubertal event? As I told you, hair growth is not dependent on estrogen. Hair growth is dependent on androgens. Right? So which event is not dependent on estrogen? It is hair growth. Clear to all of you? Right. Now, if you are getting a question on primary amenorrhea. Now, whenever you get a question on primary amenorrhea, first I want all of you to understand. Whenever a question comes which says that there is primary amenorrhea with proper breast development and scanty pubic hair, इसका क्या मतलब हुआ? स्कैंटी प्यूबिक हेयर का मतलब कि एंड्रोजन में प्रॉब्लम है. Obviously, because pubic hair development depends on androgens. So whenever your question is saying that there is scanty pubic hair but breast development is proper, there has to be only one diagnosis, and that is androgen insensitivity syndrome. This is something which I want all of you to remember. Whenever your question says proper breast development and your question says scanty pubic hair in a female with primary amenorrhea, it can be nothing other than androgen insensitivity syndrome. Androgen insensitivity syndrome individuals actually are 46XY individuals. Now, if the same question is saying that the external genitalia of the patient is exactly female-like, that means I am dealing with complete androgen insensitivity syndrome. But if your question says that external genitalia are ambiguous, then it means it is partial androgen insensitivity syndrome. Very, very simple. Question कहता है that breast development is proper, pubic hair scanty. Right? Patient coming to you with primary amenorrhea, it has to be one diagnosis, and that is androgen insensitivity syndrome. If external genitalia are exactly female-like, it is complete androgen insensitivity. If external genitalia are ambiguous, it is partial androgen insensitivity syndrome. Now, coming to ambiguous genitalia. All of you know that the most common method of sex determination is by looking at external genitalia. right? But sometimes when you look at the external genitalia, you are unable to decide whether the external genitalia are male or female. Why? Because some structure is, for example, clitoris. Clitoris is either appearing too large, right, to be called as clitoris, or penis is appearing too small to be called as penis, right? So whenever your question is saying that there is clitoromegaly, or whenever your question is saying there is micropenis, or there is labioscrotal fold, that we are unable to decide whether it is labia or whether it is scrotum. All these indicate that the question is talking about ambiguous genitalia. That means by looking at the genitalia, I cannot decide whether it is male or whether it is female genitalia, right? So now your question says that a newborn child is born with ambiguous genitalia. What is the next step? Please be very careful. Do not say that the next step is karyotyping. Although, if I want to be very sure about the sex, I will have to do karyotyping, but that is not the next step. Next step is physical examination. On physical examination, if gonads are palpable, that means they are the undescended testes. That means they are undescended testes, and that means I am dealing with 46XY individual, right? If gonads are not palpable, that means they are ovaries, and I am dealing with 46XX individual, right? Now, if the gonads are palpable and I am getting ambiguous genitalia, that means 46XY. So either it is androgen insensitivity, kaun sa wala androgen insensitivity? Partial androgen insensitivity. Just hold on. Partial androgen insensitivity. I am dealing with partial androgen insensitivity, or I am dealing with congenital adrenal hyperplasia. Most common is partial androgen insensitivity. Second is congenital adrenal hyperplasia, right? Now, if it is 46XX, right, that means the gonads are not palpable. If gonads are not palpable, that means I'm dealing with 46XX, and most common cause of ambiguous genitalia in 46XX individual is congenital adrenal hyperplasia. Which enzyme deficiencies lead to ambiguous genitalia in XX individual? Two very common enzyme deficiencies, in which most common is 21 alpha hydroxylase enzyme deficiency and 11 beta hydroxylase enzyme deficiency. Both these enzyme deficiencies, they also lead to decrease in aldosterone levels and decrease in corticosteroid levels, and that is why it is an emergency condition, right? So that is why this becomes an emergency condition. Now, when it comes to 46XY, 46XY individual with ambiguous genitalia means it is partial androgen insensitivity syndrome, or it could be congenital adrenal hyperplasia. This congenital adrenal hyperplasia is due to enzyme deficiencies starting with number 17. What are the number 17 enzyme deficiencies? 17-20 lyase deficiency or 17 hydroxylase deficiency. So enzyme deficiencies starting with number 17, they lead to congenital adrenal hyperplasia, and they lead to ambiguous genitalia in XY individuals. Enzyme deficiencies 21 alpha hydroxylase and 11 beta hydroxylase, they lead to ambiguous genitalia in 46XX individuals. Now my question to you is, which enzyme deficiencies can lead to ambiguous genitalia in both XX and XY? Ambiguous in both XX and XY. It is 3 beta HSD deficiency, right? and P450OR deficiency. These are two enzyme deficiencies which lead to ambiguous genitalia in both of them, right? That is males as well as females. Clear to all of you? So this is something very important. Congenital adrenal hyperplasia में which enzyme deficiency leads to ambiguous genitalia in XX? Which enzyme deficiencies lead to ambiguous genitalia in XY, and which leads to ambiguous genitalia in both of them? Right? Okay. So same over here. This is what I have written. You can fill it up now. Ambiguous genitalia in females, ambiguous genitalia in males, and in both males and females. Clear to all of you? Okay. Now, this was a question which was asked in Neet PG 2020. A 13-year-old child visits Gynae OPD with complaint of not attaining menarche and her karyotype is 46XX. On examination, there is clitoromegaly. That means there is ambiguous genitalia. I am getting ambiguous genitalia in 46XX individual. What enzyme deficiency is likely to be seen in above condition? Tell me. 46XX individual में which enzyme deficiency? Most common 21 alpha hydroxylase. If 21 alpha hydroxylase would not have been given, then I would have marked the answer as 11 beta hydroxylase. Clear to all of you? Yes? Okay. Now, in case of congenital adrenal hyperplasia, what is the screening test? Screening test is you have to measure the levels of 17-hydroxyprogesterone. If 17-hydroxyprogesterone levels are less than 200 nanograms, then it rules out congenital adrenal hyperplasia. If 17-hydroxyprogesterone levels are between 200 to 800 nanograms, then you have to do the diagnostic test, and that is ACTH stimulation test. And if 17-hydroxyprogesterone levels are more than equal to 800 nanograms, then that means congenital adrenal hyperplasia is confirmed. No further testing is required. Right? No further test. Clear to all of you? That is how you make a screening. That is a screening test for congenital adrenal hyperplasia. What will be the diagnostic test? Overall, whenever there is ambiguous genitalia, what is the diagnostic test for ambiguous genitalia? The diagnostic test for ambiguous genitalia will always be karyotyping. Right? So, the diagnostic test for ambiguous genitalia will be karyotyping. But the first thing which you are going to do whenever a child is born with ambiguous genitalia is physical examination to see whether the gonads are palpable or not, because that is going to give you a rough idea whether you are dealing with 46XX or whether you are dealing with 46XY individual. Clear? Okay. Now where is the SRY gene located? I'm sure this is something which all of you know, and you are going to write it quickly and tell me. Where is the SRY gene located? Tell me quickly, where is the SRY gene located? This question though, I'm sure all of you are going to write it quickly and are going to tell me, where is the SRY gene located? So many times this has been asked. On Y chromosome, I know, short arm or long arm, proximal end or distal end. Excellent, Manish. It is distal end of short arm of Y chromosome. Very, very important one-liner. Now, next important thing. Whenever your question is saying that there is a female who complains of primary amenorrhea, there are palpable gonads. जब भी question palpable gonads कहे, that means there is 46XY. अगर bilateral inguinal hernia बोले, please understand, bilateral inguinal hernia means that probably these are undescended testes. So these are the hints which the question is going to give you that they are talking about XY karyotype. What are the hints which you are going to get? Whenever a question says that there is primary amenorrhea with palpable gonads or primary amenorrhea with bilateral inguinal hernia or primary amenorrhea with testosterone levels compared to male testosterone levels, that means they are talking about 46XY individuals. Right? Now, in 46XY individuals, why are they being called as a female? They are being called as female because their external genitalia are exactly female-like. Question is not saying that there is ambiguous genitalia. Question is saying a female comes to you with primary amenorrhea, with palpable gonads or with bilateral inguinal hernia, right? That means it is 46XY, and that means external genitalia exactly female-like. Now, what are the differential diagnoses in these conditions? In which condition a 46XY will have exactly female-looking external genitalia? 3 conditions: androgen insensitivity syndrome, Swyer syndrome, and 5-alpha reductase deficiency. So you should know how to differentiate between the 3. When it is androgen insensitivity, when it is Swyer syndrome, and when it is 5-alpha reductase deficiency. So let's talk about all 3 of them. In all 3 of them, the karyotype is 46XY. In all 3 of them, because they are XY individuals, the gonads will be testes. Right? Now, the problem is in Swyer syndrome, the testes are dysgenetic. That means they are not functioning. In other 2, testes are absolutely normal. There is no problem with the testes. Right? Why are the testes not functioning or dysgenetic in Swyer syndrome? This is happening due to point mutation in SRY gene, and that was a question which was asked in one of the INICT exams, that why is there Swyer syndrome? It is because of point mutation in SRY gene. Right? Now, in androgen insensitivity syndrome, because these individuals are insensitive to androgens, and all of us know that androgen, that is testosterone, is required for Wolffian duct to develop. So in case of androgen insensitivity syndrome, Wolffian duct is absent, right? And that is why there is no internal genitalia, and Mullerian duct is also absent. So no Mullerian duct, no Wolffian duct, because Sertoli cells are functioning normally. Testes normal ka matlab Sertoli cells normal and Leydig cells normal. Because Sertoli cells are normal, they will secrete Mullerian inhibiting substance, and so Mullerian duct will regress. Leydig cells will form testosterone, but these individuals are insensitive to testosterone. So in them, the Wolffian duct will regress. So neither male internal genitalia nor female internal genitalia. External genitalia exactly female-like. In androgen insensitivity syndrome, the testosterone, this is a very, very unique point. The testosterone gets converted into estrogen, and that is why they have proper breast development. Proper breast development. Pubic hair and axillary hair will be scanty because they are insensitive to androgens. Right? Now, please remember, in case of androgen insensitivity syndrome, this is exactly, the hormonal profile is exactly like PCOS. PCOS के patients में LH levels are increased, FSH levels normal, testosterone increased. This is somewhat like PCOS. So, if you are forgetting that what happens in androgen insensitivity syndrome to the hormones, just remember that it is exactly like PCOS. Now, in your questions, instead of saying proper breast development, they can also say breast development corresponds to Tanner stage 4 or 5, and pubic hair corresponds to Tanner stage 1. Right? So whenever you are getting a question on androgen insensitivity syndrome, in androgen insensitivity syndrome, there will be no internal genitalia, external genitalia exactly female-like, breast development proper, pubic hair scanty, LH, FSH and testosterone exactly like PCOS. I hope this you will remember, right? Okay. Now coming to Swyer syndrome. In Swyer syndrome, testes are dysgenetic. Now, if testes are dysgenetic, that means Sertoli cells are not functioning and Leydig cells not functioning. Because Leydig cells are not functioning, that is why there is no testosterone, and because Sertoli cells are not functioning, that is why there is no Mullerian inhibiting substance. And if Mullerian inhibiting substance is not there, so they will have female internal genitalia. Common sense है ना? Mullerian inhibiting substance नहीं है तो Mullerian duct will grow and it is going to lead to female internal genitalia. So Swyer syndrome में the internal genitalia are female. Right? Androgen insensitivity में no internal genitalia. So androgen insensitivity में uterus was absent. Swyer's में uterus will be present. Are you understanding this? Okay, then external genitalia. External genitalia exactly female-like. Now, in case of Swyer syndrome, because testes are not functioning, so what will happen to testosterone levels will be low. Because testosterone levels is low, so pubic hair scanty, and because testosterone levels are low, they will not get converted into estrogen, so breast development will be absent. Right? Breast development and pubic hair, both of them are absent or scanty. Right? What will happen to testosterone levels? Testosterone levels are low. Because testosterone levels are low, the negative feedback on LH and FSH is gone. So LH and FSH levels are high. Clear to all of you? This is what you get in Swyer's syndrome. Clear? I hope you will be able to make difference between Swyer's and androgen. Androgen में breast development proper होगा. Swyer's में breast development absent होगा. In androgen insensitivity, uterus will be absent. In Swyer's, uterus will be present. Right? Okay. Now coming to 5-alpha reductase deficiency. In 5-alpha reductase deficiency, please understand testes are normal. And they are normally producing testosterone. The problem is that testosterone is not getting converted into dihydrotestosterone. And dihydrotestosterone is the one which is responsible for male external genitalia. Right? So, in case of a 5-alpha reductase deficiency, because testosterone is normal, so they will have male internal genitalia. Male internal genitalia. So, are you understanding? Right? Okay. Now, what about external genitalia? As I said, testosterone is unable to get converted into dihydrotestosterone. And because testosterone is unable to get converted into dihydrotestosterone, at birth, they will have exactly female external genitalia. Exactly female external genitalia. But at puberty, because of testosterone, the clitoris will enlarge and there will be clitoromegaly. This is extremely important point. 5-alpha reductase deficiency के patients में at birth there is no clitoromegaly. Because अगर birth पे clitoromegaly होती, I would have called it as ambiguous genitalia. They don't have ambiguous genitalia, they have exactly female looking external genitalia. At puberty, they have clitoromegaly. Yes, Palak. See, undescended testes क्यों होंगी? जहाँ कहीं भी female external genitalia होगा, जहाँ कहीं भी ambiguous genitalia होगा, there is no scrotum. Testes को descend करने के लिए scrotum चाहिए. So whenever there will be any XY individual with female external genitalia, any XY individual who doesn't have a proper scrotum, that means has ambiguous genitalia, will have undescended testes. Right? Clear to all of you, Palak? So any XY individual with female external genitalia or ambiguous genitalia will have undescended testes, and that is why I said undescended testes means XY individual. Bilateral inguinal hernia means XY individual. Understood, Palak? Okay, coming back to 5 alpha reductase. 5 alpha reductase के patients में एक ही problem which you people have is that, ma'am, why in 5 alpha reductase breast is absent? Androgen insensitivity में testosterone is getting converted into estrogen. Why not in 5 alpha reductase? This, as I always tell in my classes also, that this testosterone getting converted, Prachi, I'm not getting your question. Hold on. Abhi meko ek baar aane do, because your question has got a little up in the chat box. I can't read your question. Just let me explain this. I'll come to your question also. Right? Okay. Now coming to back to this. I was telling you, testosterone gets converted into estrogen only in one condition, and that is androgen insensitivity. इसके अलावा कहीं पर भी testosterone will not get converted into estrogen, and that is why in 5 alpha reductase breast development absent. Pubic hair कैसा होगा? Pubic hair normal होगा, right? अब pubic hair ना दोनों चीज़ें होती हैं. Sometimes pubic hair can be normal, sometimes it can be scanty. Pubic hair is because pubic hair का development depends both on testosterone and dihydrotestosterone. So it can be normal or it can be scanty, right? What about LH, FSH and testosterone levels? Testosterone levels normal. So LH, FSH normal, right? So in case of 5 alpha reductase deficiencies, LH, FSH, testosterone levels, all of them are normal. Clear to all of you? Any confusions which anyone has, just let me know. Any confusions which you have related to this part, just let me know if there is any confusion related to this part only. I am not talking about any other part. पहले मुझे बता दो, any confusions related to this part I will solve and then I'll go ahead. Any confusions related to this part? Now, I wanted to share a question with you. I'm just trying to find that question. There was a question. I'll just share that question with you. Right. I'll share a question which was asked in your exams. I'll just share that. Okay. Now, all 3 of them are going to present with primary amenorrhea, and question will say that there is bilateral inguinal mass or hernia. Right. Now, coming to definition of primary amenorrhea, very, very important. Absence of menstruation by 15 years of age with proper breast budding, or by 13 years of age in absence of breast. Right, so 15 and 13 you have to remember. Please remember, normally when puberty happens at 10.5 years, menstruation happens by 12.5 years. That means normally there is a gap of 2 years between onset of puberty and menstruation. Now suppose there is a female who has had onset of puberty, that means thelarchy is present, but there within 3 years of thelarchy menstruation did not happen. Normally the time gap is 2 years. Ab 3 years have passed, breast budding हो गई, onset of puberty हो गई, 3 years have passed but patient did not menstruate. That is also called as primary amenorrhea. Right? Now, all cases of primary amenorrhea can be broadly divided into 2 categories: uterus absent, uterus present. So whenever you get a question, see whether they are talking about uterus absent or uterus present. If your question is saying uterus absent, then there can be only 2 differential diagnoses. Either it can be Mullerian agenesis or it can be androgen insensitivity syndrome. And if your question is saying uterus present, then either it has to be cryptomenorrhea, or it has to be Kalman syndrome or Turner's syndrome or Swyer's syndrome. These are the 4 conditions where uterus is present and still your patient is having primary amenorrhea, right? Now, whenever a female comes to you with primary amenorrhea, how do you work up? You are going to do a physical examination. You are going to see whether the breast is present or not, and external genitalia, whether they are exactly external genitalia of a female or whether they are ambiguous. You are going to do a urine pregnancy test. Please remember, urine pregnancy test is also done in primary amenorrheas, right? Then you are going to do an ultrasound to know whether uterus is present or not. You are going to check her FSH levels. This is what you do whenever a patient comes to you with primary amenorrhea. Best investigation for primary amenorrhea is karyotyping. But all this is the sequence which you have to follow whenever a patient comes to you with primary amenorrhea. Now, if your question says that there is primary amenorrhea with cyclical pain in abdomen, right? Uterus present, cyclical pain in abdomen. जब भी question ये कहेगा कि there is cyclical pain in abdomen, it has to be only one diagnosis, and that is cryptomenorrhea or hidden menstruation. What do you mean by cryptomenorrhea? Cryptomenorrhea means that a patient is menstruating normally, but the menstrual blood fails to come out. Why does this happen? This happens most commonly because of imperforate hymen. Imperforate hymen. Now, in case of imperforate hymen, what is the hint which the question is going to give you? Question will say that on local examination there was a tensed, bulging hymen and cough impulse was present. The other reason for cryptomenorrhea could be transverse vaginal septum. Right? In transverse vaginal septum, cough impulse is absent and hymen is normal. What is the best way to differentiate between transverse vaginal septum and imperforate hymen? MRI. MRI. Now, whenever there is going to be a question on cryptomenorrhea, question will say uterus is present. Rather, in cryptomenorrhea patients, because blood is going to collect in uterus, uterus will be enlarged. That is, there is going to be hematometra. LH-FSH levels will be absolutely normal. Breast development of the patient will be absolutely normal. Pubic hair and axillary hair will be absolutely normal. And because blood is collecting not only in uterus, it is also collecting in vagina. So it can lead to pressure on urethra, and that can lead to urinary retention. So patient may also complain of urinary retention. Right? So this is, so whenever your question is saying primary amenorrhea with cyclical pain in abdomen, it has to be cryptomenorrhea. Right? Now, how do you manage imperforate hymen? Management of imperforate hymen is by giving a cruciate incision on the hymen. Please understand, whenever you get a question on cryptomenorrhea, if your question is not saying about, it is not talking about the local examination, and you have to choose between imperforate hymen and transverse vaginal septum, you are always going to choose imperforate hymen, because imperforate hymen is the more common cause of cryptomenorrhea. Right? Now, next question which they give you is on the types of hymen. They give you images and they ask you what type of hymen, in which septate hymen image is very, very important. Cribriform hymen image is very, very important, right? This is how imperforate hymen looks like, where there is no opening in the hymen for menstrual blood to come out, right? Then, now if your question says that there is primary amenorrhea with uterus present, as I told you, uterus present में cryptomenorrhea होता है, then there can be Turner syndrome, there can be Swyer syndrome, there can be Kalman syndrome. Cryptomenorrhea के बारे में I've told you, always in the question there is going to be cyclical pain in abdomen present. Now if your question is saying primary amenorrhea with uterus present, absent breast and pubic hair, and LH, FSH and estrogen levels are decreased. LH, FSH, estrogen levels decreased means they are talking about Kalman syndrome. In Kalman syndrome, LH, FSH, estrogen levels are decreased. Where is the lesion? Whenever LH, FSH, estrogen levels are decreased, that means the problem is either in hypothalamus or the problem is in pituitary. LH, FSH, estrogen levels decreased is called as hypogonadotropic hypogonadism. Hypogonadism, right? So if the problem is in hypothalamus or pituitary leading to primary amenorrhea, it means it has to be Kallmann syndrome. In Kallmann syndrome, the question will say height of the patient is normal and anosmia will be present. Inability to smell will be present. How do you manage a patient of Kallmann syndrome? You have to give pulsatile GnRH. Remember, in Gynae, it's a simple rule. Whatever is deficient, you have to give. In Kallmann syndrome, the problem is in hypothalamus, so GnRH is absent, so I have to give pulsatile GnRH. Now, if you get a question which says that there is primary amenorrhea with uterus present, absent breast and absent pubic hair, but now your question is saying LH increased, FSH increased, estrogen decreased. LH increased, FSH increased, estrogen decreased is called as hypogonadotropic hypogonadism. Now, whenever there is hypogonadism, that means the lesion is in ovary. That means the lesion is in gonads. So it could be gonadal dysgenesis. Gonadal dysgenesis के दो important reasons होते हैं. Gonadal dysgenesis के दो causes होते हैं. Number one, Turner's syndrome. That is 45XO. And number two, Swyer's syndrome. So whenever you are getting LH increased, FSH increased, estrogen decreased, it means it is hypergonadotropic hypogonadism. That means the problem is in ovary, and that means there is gonadal dysgenesis, which could be due to Turner's syndrome, which could be due to Swyer's syndrome, which is 46XY. Now, if your question further says that there is short stature, then I know I am dealing with Turner's syndrome. And if your question says normal stature and bilateral inguinal mass, that means I am dealing with Swyer's syndrome, 46XY, right? So as I told you that in gonadal dysgenesis, short stature means Turner's syndrome. Turner's syndrome में karyotype is 45XO. In Turner's syndrome, there are streak ovaries. Please remember, streak ovaries are never removed because they do not lead to malignancy. In Turner's syndrome, you get certain additional findings of Turner's syndrome also, like webbing of neck, low posterior hairline, shield-shaped chest, cubitus valgus, all that you get, right? Then, if your question is saying normal stature, that means it is Swyer's syndrome. As I told you, in Swyer's syndrome, karyotype is 46XY, and your question will also say that there is bilateral inguinal hernia. So that is how you make a diagnosis of primary amenorrhea. Kallmann syndrome, Turner's syndrome, Swyer's syndrome, and I also told you everything about cryptomenorrhea, androgen insensitivity syndrome, Mullerian malformation, Mullerian agenesis, you know. Now come over here. This is a question which was asked in Neet 2020. A mother brings her 16-year-old daughter to Gynae OPD with complaint of not attaining menarche. She has history of cyclical pain in abdomen. On further examination, a midline abdominal swelling was present and a bulging mass was present in vagina. What do you suspect? As I told you, whenever your question is saying cyclical pain in abdomen, it means they are talking about cryptomenorrhea, right? And because your question is saying that it has given options of imperforate hymen and transverse vaginal septum, which is the more common one, they have not told us anything about local examination. So I'm going to say it is imperforate hymen. Yes, in Swyer's syndrome, you have to do gonadectomy. In Swyer's syndrome, there are dysgenetic testes, and dysgenetic testes means you have to do gonadectomy. Clear to all of you? Okay. Now, this question. A 16-year-old female visits gynae OPD with complaint of cyclical pain in abdomen and history of no menarche. Her general examination shows normal breast development, pubic hair. Local examination shows bluish bulging hymen. On per rectal examination, uterus is palpable. Most appropriate management. Again, I told you cyclical pain in abdomen means cryptomenorrhea. Here the question is saying that there is bulging hymen. You can see from the image also that it is a case of imperforate hymen. So what am I going to do? I am going to give a cruciate incision on the hymen. All these are your PYQs. Next question. A mother brings her 18-year-old daughter to gynae OPD with complaint of not attained menarche, normal FSH and LH, normal breast development and pubic hair development, absent uterus, karyotyping 46XX. अब absent uterus में I have only two conditions, Mullerian agenesis and androgen insensitivity syndrome. Mullerian agenesis is 46XX. Androgen insensitivity is 46XY. Right? Now tell me, they are saying that in this question they are saying uterus absent. So some of you are saying it can be Swire's syndrome. Chalo, let us think about Swire's syndrome. Okay, in Swire's syndrome, uterus is absent. Now tell me, your question is saying normal FSH-LH. In Swire's syndrome, do you get normal FSH-LH? No. LH-FSH is increased. In Swire's syndrome, do you get normal breast development? No. What do you get? You get absent breast development. So it cannot be Swire's. Can it be Turner's? No. Why? Because in Turner's, uterus is present. So I am left with two options, Mullerian agenesis and androgen insensitivity. Because they are saying 46XX, it is Mullerian agenesis. Because they are saying that normal breast development and normal pubic hair development. In androgen insensitivity, pubic hair is absent. Right? So it cannot be androgen insensitivity. Another reason why it can't be androgen insensitivity is in androgen insensitivity, LH is increased, FSH is normal. So it cannot be androgen insensitivity. Clear? Is that clear to all of you? So answer over here is Mullerian agenesis. In Mullerian agenesis, the problem is that there is absent Mullerian duct. Right? These are 46XX individuals. FSH will be absolutely normal, LH will be normal, estrogen will be normal because their ovaries are normal. Ovaries develop from genital ridge. Right? Ovaries develop from, oh yes, in Swire's uterus is present. Sorry. Some of you had written answer D there, so I was just getting confused. In Swire's uterus is present. Right? So it cannot be Swire's. Anyway, it cannot be Swire's. Now, coming why it is Mullerian agenesis. In Mullerian agenesis, ovaries are absolutely normal. Ovaries are normal, so it means estrogen normal. So LH, FSH normal. Yes, beta. I just got swayed away with your chat. In Swire's, uterus is present. Yes, you are absolutely right. And as it is, we have ruled out Swire's. We are not saying that the answer is Swire's because of multiple other reasons, because LH, FSH and breast development also. Yes, you are absolutely right. Okay. I just got swayed away. Sorry. Clear? So that is what I'm saying. It cannot be Swire's. All those who've written absent secondary sexual characteristics, that's right. It cannot be Swire's. That is what I've written. Breast development is absent in Swire's. Okay? Now, coming to secondary amenorrhea. Secondary amenorrhea is absence of menstruation for 90 days, that is for 3 months in a female who was previously menstruating normally. Most common cause of secondary amenorrhea is pregnancy. So, whenever you have got a patient of secondary amenorrhea, you have to do UPT. Other causes are increased prolactin levels, so you have to do serum prolactin. Then thyroid dysfunction can also lead to amenorrhea, so TSH levels, then LH, FSH and estrogen levels. So these are the investigations which you are going to do whenever a patient comes to you with secondary amenorrhea, because pregnancy is a very important cause, increased prolactin is a very important cause, and thyroid dysfunction is a very important cause. So you have to rule out pregnancy, you have to check her prolactin levels, you have to check her TSH levels. Then you also have to check LH, FSH and estrogen levels. Now, if your question says that there is secondary amenorrhea with FSH increased, as I told you every time in class, FSH increased ka matlab hai that the problem is in ovaries. Whenever FSH, LH are increased, it means the problem is in ovaries. Please remember, normal FSH levels are less than 10 international units. Right now, whenever FSH levels are high and there is secondary amenorrhea, I know that the problem is in ovary. And what is the problem? The problem is POI, primary ovarian insufficiency, that is premature menopause. Premature menopause. That means menopause happening at less than 40 years. If the FSH levels become more than equal to 25 international units, that is suggestive of POI, and if they are more than 40 international units, that is diagnostic of POI. Please remember, menopause is a clinical diagnosis, but to diagnose POI, you have to do serum FSH levels on 2 occasions 1 month apart. But for menopause, which is happening at normal age, you don't have to do any investigation. Menopause in itself is a clinical diagnosis. Now, what will be the additional feature of a female who's coming to you with POI? Additional feature will be that she's going to complain to you of hot flashes, right? Or she may come to you as a case of secondary infertility, right? Now, in patients of POI, anti-Mullerian hormone is decreased. Anti-Mullerian hormone, it is released by the preantral and antral follicles. It is released by the preantral and antral follicles, the granulosa cells. The granulosa cells of the preantral and the antral follicles, or the small antral follicles, they release anti-Mullerian hormone in females from puberty onwards. So in case of POI, all follicles are less, right? Because follicles are less, so anti-Mullerian hormone levels will be decreased, right? So whenever you get a question on secondary amenorrhea with FSH levels decreased, with FSH levels increased, you only and only have to think about POI. FSH increased means problem is in ovary, and that means it is POI. Right. Now, when your question is saying that there is secondary amenorrhea with normal FSH levels, normal FSH levels means there can be two differential diagnoses. One can be PCOS and the other one can be Asherman syndrome. Your differential diagnosis has to be either PCOS or it has to be Asherman syndrome. These are two conditions which are going to present to you with secondary amenorrhea in with FSH normals. What are you saying? What age it is considered to be POI? If menopause is happening at less than 40 years. Less than 40 years is POI. Right? Now, how am I going to know it is PCOS? In PCOS, your question will say LH levels increased, FSH normal. Then it is PCOS. FSH levels are normal in PCOS, but LH levels are high. Just now only I told you that there are two conditions where LH levels will be high, FSH normal. One is PCOS, one is androgen insensitivity syndrome. So if your question says secondary amenorrhea with LH high, FSH normal, it is PCOS. Primary amenorrhea with LH high, FSH normal, androgen insensitivity syndrome. Right? Now in PCOS, how do you make a diagnosis of PCOS? By Rotterdam criteria. Rotterdam criteria says out of the following three, Any two should be present and then you call it as PCOS. What are they? Number one, increase androgen levels. These increased androgen levels can be present clinically in the form of hirsutism or biochemically, right? Number two, ovulatory dysfunction. Ovulatory dysfunction in the form of oligomenorrhea or in the form of amenorrhea. And number three is polycystic ovaries on ultrasound. Polycystic ovaries on ultrasound. When do you call it as polycystic ovaries on ultrasound? If the number of follicles are more than equal to 12 follicles, 2 to 9 millimeters in size, or if the volume of the ovary is more than 10 cc, right? Now, as I told you, that out of these three, any two should be present to make a diagnosis of PCOS. This is what is Rotterdam's criteria. In Rotterdam criteria, the number of follicles are more than equal to 12. Recently, the European and American Society have said that to be called as polycystic ovaries, the number of follicles should be more than 20. But in Rotterdam criteria, it is still 12, right? Now, in case of PCOS, patient will come to you either with hirsutism. Along with these things, question will say that there is hirsutism or obesity or insulin resistance will be present. What happens to anti-Mullerian hormone in PCOS levels? In PCOS patients, anti-Mullerian hormone levels are increased. Why? Because small follicles are increased. It's multiple small follicles which will be now found in the ovary. What happens to LH levels? Increased. Progesterone challenge test is positive. What do you mean by progesterone challenge test positive? Progesterone challenge test positive means if you give her progesterone for some days and then you withdraw it, bleeding will be present. Estrogen levels are normal if it is a thin patient and it is increased if it is obese patients. Especially E1 levels are increased in obese patients. Testosterone levels are high in PCOS patients. DHEA sulfate levels are also slightly increased in PCOS patient. Please remember, in PCOS patients, the major source of testosterone is ovary, but small amount of testosterone, the extra testosterone, is also coming from adrenal glands, and that is why DHEA sulfate levels are increased in PCOS patients. In patients of PCOS, testosterone levels are high. How much high? They will be more than 70 nanograms, but they are less than 200 nanograms. Progesterone levels are decreased in PCOS patients because in PCOS patients there is an ovulation. When it comes to sex hormone binding globulin is decreased in patients of PCOS because of androgen and insulin resistance. Because of excessive androgen and insulin resistance, sex hormone binding globulin levels are decreased. Right? So these are very, very important hormonal changes which they ask in PCOS patients. Clear? Now, if your question is saying FSH levels normal, then also the second diagnosis, as I told you, could be Asherman syndrome. Now, how do you come to know that they are talking about Asherman syndrome? In a question on Asherman syndrome, they are going to tell you progesterone challenge test negative, estrogen and progesterone challenge test negative. What do you understand by that? This means that whether even if I give her estrogen and progesterone, and so I am giving her estrogen and progesterone like a normal menstrual cycle, and then I withdraw. I expect a female to menstruate when I give her estrogen and progesterone. But in Asherman syndrome, because of additions present, the patient will not menstruate. So whenever your question says estrogen and progesterone challenge test negative, it means they are talking about Asherman syndrome. In Asherman syndrome, what is the problem? The problem is intrauterine additions plus a thin endometrium, right? Now, in Asherman syndrome, in contrast to PCOS, LH levels are also normal, FSH levels are also normal, and estrogen levels are also normal. So everything is normal because the problem is in uterus. The problem is not in hypothalamus, not in pituitary, not in ovary. LH, FSH, estrogen levels normal, right? Estrogen and progesterone challenge test negative, progesterone challenge test also negative. What is the most common group of symptoms which you get in Asherman syndrome? The most common group of symptoms are menstrual symptoms. But what is the most common symptom which you get in Asherman syndrome? Most common symptom is infertility, followed by secondary amenorrhea, followed by hypomenorrhea. Right? What is the most common cause of Asherman syndrome? Most common cause of Asherman syndrome is excessive curettage. And what is the most highest risk for Asherman syndrome? Highest risk for Asherman syndrome is when you do curettage in postpartum period. Curettage in postpartum period. That has got the highest risk for Asherman syndrome. Right? Now, in Asherman syndrome, please understand, when you do HSG on Asherman syndrome, in Asherman syndrome, when you are going to do HSG, you are going to get multiple filling defects. You get multiple filling defects which have got irregular boundaries, right? So you get a moth-eaten appearance. Multiple filling defect with irregular boundaries. Right? So just let me quickly show you how do you get HSG appearance in Asherman syndrome. In Asherman syndrome, as I told you, you are going to get multiple filling defects which will have irregular boundaries. So see over here. Multiple filling defects with irregular boundaries. This is what you get in Asherman syndrome. Filling defect you also get in a fibroid or a polyp. But in a fibroid or a polyp, you are going to get a very smooth outline. If you are getting a smooth outline, then that is what is a polyp or a fibroid. But if you are getting multiple filling defects with irregular outline, that is what is moth-eaten appearance, or that is also honeycomb appearance, and that is what is Asherman syndrome. What is the investigation of choice in Asherman syndrome? The investigation of choice in Asherman syndrome is hysteroscopy. And what are you going to get on hysteroscopy? You are going to get multiple adhesions. How do you manage Asherman syndrome? You are going to go for hysteroscopic adhesiolysis, and so that the adhesions do not form again, you are going to put a pediatric Foley's catheter, and so that the endometrium, which is thin, you can build it. You will have to give estrogen, but if you give estrogen alone, it will lead to endometrial cancer. So you have to give estrogen and progesterone for 3 months for managing Asherman syndrome. Now, whenever you are doing HSG, right, what is the instrument which you use for doing HSG? You use a Leach-Wilkinson cannula to do an HSG. Leach-Wilkinson cannula, it is going to have multiple transverse serrations, right? That is how, this is the instrument which is used for doing HSG. What is the ideal time for doing HSG? It is in the pre-ovulatory phase between day 7 to day 10. Which dye are you going to use for HSG? It is the water-soluble iodinated dye, that is urographin, which is used for doing HSG. What are contraindications for doing HSG? Pregnancy is a contraindication for doing HSG. If your patient has active PID or active genital TB, then it is a contraindication for doing HSG. Now, once you have a genital TB patient come to you with infertility. So whenever you have a genital TB patient, I have to do HSG in her because genital TB can lead to blockage of the tube. And I am saying that in active genital TB, I don't have to do HSG. So which means that whenever a patient of genital TB is going to come to me, I'm first going to give her ATT and then I am going to do HSG. when you do HSG in a genital TB patient, there are certain characteristic appearances which you get, on which you can get question. Number one characteristic appearance is beaded appearance of the tube. So you can get a beaded appearance of the tube, or you can get a lead pipe appearance of the tube. The tube appears absolutely straight. Or you can get a golf stick appearance of the tube, or you can get a cotton wool appearance of the tube. Other than this, you can also get, you can get a bilateral cornual block, right? So other than this, you can get a bilateral cornual block or a tobacco pouch-like appearance of the tube. Please remember, genital TB can also lead to Asherman syndrome, right? So these are the appearances which you get in case of genital TB on HSG. Clear to all of you? Right. Coming back to our topic of secondary amenorrhea. Now, in secondary amenorrhea, if your question says that there is secondary amenorrhea with FSH decreased. Now, whenever your question is saying secondary amenorrhea with FSH decreased, it means that the lesion is either in hypothalamus or the lesion is in pituitary, right? In hypothalamus, the problem could be that patient is doing excessive exercise, or patient is going for excessive dieting, or there is bulimia. In pituitary, the problem could be Sheehan syndrome, or it could be a prolactin secreting tumor, that is prolactinoma. So whenever your question says FSH decreased, I am thinking about all these problems, that either the problem is in hypothalamus or the problem is in pituitary. Now, how am I going to make the diagnosis? Because question will tell me something else. If question is saying that your patient has FSH decreased, secondary amenorrhea, headache, visual disturbances, infertility, galactorrhea. Headache, visual disturbances means it's a pituitary tumor which is giving pressure symptoms. Galactorrhea means it's a prolactin secreting pituitary tumor. So that means it is a prolactinoma. Right? Now, in these cases, the prolactin levels are going to be high. Because prolactin is high, prolactin will have a negative feedback on GnRH, and that is why patient has come to you with secondary amenorrhea. On MRI, you are going to get a space occupying lesion. Now, if I ask you what is the most common symptom of a prolactinoma, please don't say that the most common symptom of a prolactinoma is galactorrhea. Most common symptom of prolactinoma is not galactorrhea, it is secondary amenorrhea. Right? Okay. Now, if your question says that there is secondary amenorrhea with decreased FSH with inability to lactate, patient is saying that there is inability to lactate. That means it is Sheehan syndrome. Sheehan syndrome. In Sheehan syndrome, there is necrosis of anterior pituitary gland. So prolactin levels are decreased, LH and FSH levels are decreased. When I am going to do when I am going to do MRI, I am going to get empty sella turcica. Right? So patient will say that after delivery she was unable to feed her baby and her secondary amenorrhea is persistent. After delivery, if the patient is not feeding, I expect her menstruation to return. But in Sheehan syndrome, she will say, I did not feed my baby, but my menstruation also did not return. That means it is Sheehan syndrome, right? Now, if your question is saying that there is FSH levels are decreased and MRI is absolutely normal. MRI absolutely normal means the problem is in hypothalamus, which I told you could be excessive exercise, excessive dieting, or it could be stress, it could be anxiety. All these can be the problems. Clear to all of you how to make a diagnosis of secondary amenorrhea? So see over here a question which was given in your exams. The question says, Mrs. Rekha, having her child 2 years of age, presents to her family obstetrician with complaint of pruritus vulva and amenorrhea. She gives history of severe blood loss and failure to lactate during pregnancy. She is lethargic and has cold intolerance, multiple skin infections. All this points towards Sheehan syndrome. Why? Because in Sheehan syndrome, the problem is in anterior pituitary, so all hormones released by anterior pituitary will be decreased. ACTH will be decreased, TSH will be decreased, prolactin will be decreased, LHFSH will be decreased, right? So this over here is a case of Sheehan syndrome. Then look over here. Another question. A 26-year-old female came with history of fatigability and constipation for last 1 year. She has history of multiple blood transfusions after delivery. That means she's a case of severe blood loss after delivery. Always in Sheehan syndrome, this will be present. The necrosis of the anterior pituitary glands happens because of severe blood loss. She has lactation failure and she never regained her periods after delivery. All this points towards Sheehan syndrome, right? Okay, so prolactin disorders, I have told you. Now, some important managements which I want you to know. Whenever a question comes on PCOS, please remember the first line management of PCOS is weight loss, which has to be through diet modification and lifestyle modification. Diet and lifestyle modification, right? Now, if you're a patient of PCOS, in patients of PCOS, you are going to manage the complaint with which the patient comes to you. You are not going to give her a blanket treatment. So if your question says that patient comes to you with complaint of infertility, again, the first step is you have to advise her diet and lifestyle modification and tell her to try to conceive naturally. But if the patient is unable to conceive naturally, even after lifestyle and diet modification, then the first line management is letrozole, which becomes the drug of choice. And if letrozole is not there, then I have to give clomiphene citrate. Both of them are first line drugs, but the drug of choice is letrozole. Clomiphene citrate is not the drug of choice. Why is letrozole preferred over clomiphene citrate? The best answer for this is, in letrozole there is increased live birth rate in comparison to clomiphene citrate, right? Okay. Now the second line management of PCOS is HMG, right? Or you can also combine clomiphene citrate with other drugs. For example, if your patient has increased DHEA, then along with clomiphene citrate, I can add corticosteroid. Or I can give OCPs along with clomiphene citrate. Initially, I give her OCPs followed by clomiphene citrate. Or if patient has insulin resistance, then clomiphene citrate plus metformin. Right? So these are all second line drugs. Now please understand, if your patient comes to you with irregular cycles, if a patient of PCOS comes to you with irregular cycles, then the drug of choice is OCPs. If a patient comes to you with insulin resistance in PCOS, then the drug of choice is metformin. So second line management में I can have HMG, second line management में I can have clomiphene citrate with other drugs. That other drug could be corticosteroid, that other drug can be OCP, that other drug can be metformin. Now if your question says, what is the drug of choice for PCOS? The drug of choice for PCOS as such, this is a very stupid question to ask, but the drug of choice is OCP. Now, why is there infertility in a patient of PCOS? It is due to anovulation. Infertility in PCOS is due to anovulation. So they can ask you the tests for anovulation. The easiest test for anovulation is serum progesterone levels. Serum progesterone levels. When are you going to do serum progesterone levels? You are going to do it on day 22 of the cycle. Most commonly done test is follicular monitoring. Right? Time for the test for ovulation, all the tests for ovulation, they are done on day 22 of the cycle. What is the drug of choice for an ovulation? If a question, see, if they ask you drug of choice for an ovulation in PCOS, then I told you the answer is letrozole. But if simply a question is coming, what is the drug of choice for an ovulation, then the answer is clomiphene citrate. Now, whether it is clomiphene citrate or whether it is letrozole, for both of them, the requirement is that HPO axis should be normal. In other words, FSH levels should be normal. So, if an ovulation is happening due to pituitary ablation, the pituitary has been removed because of which an ovulation is happening. In pituitary ablation, FSH levels will be decreased, so I cannot use letrozole or clomiphene citrate. Here, as I told you, whenever in gynae, whatever is the problem, you have to treat that. Jo kam hai, whatever is deficient, give that. So whenever there is pituitary ablation, what is less? LH-FSH is less. So what is the drug of choice for ovulation in a case of pituitary ablation? LH-FSH. What is LH-FSH called as? HMG. Right? Now, what is the drug of choice for an ovulation in Kallmann syndrome? In Kallmann syndrome, again, FSH levels are decreased, so do not say it is clomiphene citrate. In Kallmann syndrome, GnRH is less, so the drug of choice becomes pulsatile GnRH. Right? Now, understand, in case of infertility, earlier a surgery was done in PCOS patient, which was called as laparoscopic ovarian drilling. In laparoscopic ovarian drilling, you burnt the stroma of the ovary. Now, when you burn the stroma of the ovary, the theca cells are destroyed, and because theca cells are destroyed, the levels of androgen decrease. So, in this case, because the levels of androgen decreased, PCOS patient was treated, right? So now over here, nowadays we don't do laparoscopic ovarian drilling because iska bahut bada disadvantage hota hai. What is the disadvantage? When I am burning the stroma of the ovaries, sometimes I burn so much stroma that it can lead to POI. The entire ovary can burn. Right? All the follicles of the ovary can burn, and that can lead to premature menopause. That is primary ovarian insufficiency. Ma'am, an ovulation drug of choice is letrozole. No, beta. If an ovulation is due to PCOS, drug of choice is letrozole. If you get a simple question that what is the drug of choice for an ovulation, it is clomiphene citrate. For PCOS, yes, it is letrozole. Have you understood this? Yes? Now comes management of hirsutism. A patient of PCOS can also present to you with hirsutism. How do you manage hirsutism? Before I tell you how do you manage hirsutism, tell me what is the most common cause of hirsutism? PCOS. What is the most common cause of rapid onset hirsutism? It is androgen secreting ovarian tumor. That's the most common cause of rapid onset hirsutism. Now, in androgen secreting ovarian tumors, the testosterone levels are more than 200, and that is why along with hirsutism, you will get features of virilization. What are the features of virilization? Features of virilization are breast atrophy, increased muscle mass, deepening of voice, clitoromegaly. Right? So you will not just get hirsutism, you will also get these features in androgen secreting ovarian tumors. Now, how do you manage hirsutism? Whenever there is a patient of hirsutism, the drug of choice is OCPs. OCPs is the drug of choice which has to be given for 6 months. Right? If there is no relief, then you have to give anti-androgenic drug, and that anti-androgenic drug is spironolactone. Please remember, spironolactone is never given alone to a reproductive age female. Right? Whenever I am giving anti-androgenic drug, I have to give OCPs along with it. Right? So, other than spironolactone, which other drugs we can use? Flutamide, finasteride, ketoconazole, or you can use topical eflornithine. If everything fails, then the last resort is continuous GnRH. right? Continuous GnRH is going to decrease LH. Because it is going to decrease LH, so the androgen production will decrease. Clear to all of you? Now, if your question says all of the following drugs can be used for managing hirsutism, except, always the answer in that except will be danazol. Why danazol? Because danazol ka side effect is hirsutism. So suppose if you forget the management of hirsutism and they ask you that what is the side, which of the following drugs cannot be used for managing hirsutism, the answer is danazol. Yes, you can also use cyproterone acetate. Flutamide, finasteride, cyproterone acetate, ketoconazole, topical drugs like eflornithine, and the last resort is continuous GnRH. Now, what is the scoring system for hirsutism? The scoring system is Ferryman-Galway score. Okay? This is all what you have to remember about PCOS. Now let us see one of the questions which was asked in your PYQs. A 19-year-old girl presented with irregular cycles and weight gain. Neck of the patient shows finding as given in the image. On ultrasound, ovaries were found to have increased volume. Which of the following treatment is true? Right. Number 1, laparoscopic ovarian drilling. Number 2, spironolactone. Number 3, lifestyle modification. Number 4, COCs. So tell me, A, B, C or D? A, B, C or D? Quickly tell me the answer. A, B, C or D? Jaldi batao. A, B, C or D? Patient has come to you with irregular cycles and weight gain. So tell me, 19-year-old patient coming to me with irregular cycle and weight gain. Irregular cycles के लिए what do I want to give her? COCs. Weight gain के लिए lifestyle modification. Is my patient coming to me because of hirsutism? No, she's not coming to me because of hirsutism. So am I going to give her spironolactone? No. Am I going to do laparoscopic ovarian drilling? As it is, laparoscopic ovarian drilling is not done these days. Right? Even if the patient is coming off for infertility and she's a 19-year-old girl, why will I do laparoscopic ovarian drilling? Bachcho, those of you who are answering it as B is wrong. As I told you, PCOS के patient में management depends upon the complaint with which the patient comes to you. Patient is not coming to you with hirsutism. Right? Patient is coming to you with irregular cycles and weight gain. So I am going to do lifestyle modification and COC. Are you understanding? Why should I be giving her spironolactone when she is not coming to me with hirsutism? Suppose even if she was coming to me with hirsutism, at the first instance, do I give her spironolactone? No. I have to give her OCPs for 6 months. Are you understanding? So your answer cannot be A, your answer cannot be B. Answer has to be C. Are you understanding, all of you? Yes? Okay. Now, coming to management of fibroid again, which is important. Now, in fibroid, the simple rule is that if it is a submucous fibroid के case में management is always surgical. So I'm talking about symptomatic fibroids. Asymptomatic fibroids do not require any treatment. If it is a symptomatic submucous fibroid, the management is always surgical. Now, a submucous fibroid presents to you with menorrhagia. A submucous fibroid presents to you with infertility. Submucous fibroid, which is a fibroid inside the uterus, will not present to you with pressure symptoms. So a submucous fibroid is going to present to you with, ma'am, we give COCs. Yes, you give COCs. COC is combined oral contraceptive, which is same as OCPs. By COC is combined contraceptive, and patient has come to you with irregular cycles. Irregular cycles ka drug of choice is OCPs. Okay? Okay. Now coming to submucous fibroid. as I told you, submucous fibroid का patient अगर symptomatic है, what symptoms are you going to get? She will come to you either with menorrhagia or with infertility. Submucous fibroid patient never comes to you with pressure symptoms. Whenever it is a symptomatic fibroid, you have to surgically manage the fibroid. If it is a type 0 or a type 1 fibroid, right, then you have to go for hysteroscopic myomectomy. And if it is a type 2 submucous fibroid, you have to go for laparoscopic myomectomy. What is type 0? What is type 1 and type 2? If a submucous fibroid is present totally inside the uterine cavity, that is type 0. If a submucous fibroid is present more than 50% inside uterine cavity, that is type 1. More than 50% inside the uterine cavity. And if a submucous fibroid is present less than 50% inside the uterine cavity, that is type 2. So when it is type 0 or type 1 fibroid, it is hysteroscopic myomectomy. When it is type 2 fibroid, it's laparoscopic myomectomy. Now, a simple rule for intramural fibroid and subserous fibroids. Intramural fibroid and subserous fibroids, if they are symptomatic, you have to give medical management. For intramural and subserous fibroids, we go for medical management. When I'm going for medical management, what are the drugs which decrease bleeding? The drugs which decrease bleeding are OCPs, progesterone, and tranexamic acid. These are the drugs which decrease bleeding but have no effect on size of the fibroid. On the other hand, the drugs which decrease bleeding and they decrease the size of the fibroid are the drugs which either decrease estrogen or they decrease progesterone, because fibroid is an estrogen and progesterone dependent tumor. So either the levels of estrogen should decrease to decrease the size of the fibroid, or the levels of progesterone should decrease to decrease the size of the fibroid. So the drugs which decrease estrogen are dominoes got late. So dominoes stands for danazol. G stands for GnRH, which could be GnRH agonist or GnRH antagonist, and L stands for letrozole. We do not prefer giving danazol because its side effect is hirsutism, right? Now the drugs which decrease progesterone are mifepristone, that is RU486, and ulipristal, right? Now, so whenever your question comes that a patient of intramural fibroid or subserous fibroid presents to you with bleeding, right? Then also this management. So whenever a question is going to come that intramural or subserous fibroid presents to you with bleeding, then the first line management is going to be these 3 drugs. And the second line management is going to be drugs which decrease estrogen or the drugs which decrease progesterone. Now, if your question says that an intramural fibroid or subserous fibroid presents to you with pressure symptoms, right? If your question is talking about pressure symptoms, then please remember, for pressure symptoms, you have to give drugs which decrease estrogen or drugs which decrease progesterone, because they are going to decrease the size of fibroid. In order to relieve pressure symptoms, you have to decrease the size of the fibroid. Now, clear to all of you? Now, coming to endometriosis. How do you diagnose endometriosis? Whenever your question says that a patient comes to you with dysmenorrhea and dyspareunia, these 2 complaints together, dysmenorrhea and dyspareunia together, means you are dealing with endometriosis, right? Along with that, patient can come to you with infertility, or patient can come to you with adnexal mass, right? that means you are dealing with endometriosis. A patient of endometriosis, as I told you, the most common complaint in a patient of endometriosis is dysmenorrhea. How do you manage dysmenorrhea in a patient of endometriosis? If it is minimal to mild dysmenorrhea, you have to treat it like primary dysmenorrhea, and management of primary dysmenorrhea is NSAIDs or OCPs, right? Now, if there is no relief from NSAIDs and OCPs, then you have to go to drugs which decrease estrogen. So you are going to give progesterone, and if progesterone is also not helpful in relieving the pain, then GnRH. So first line drug is NSAIDs and OCPs, second line drug is progesterone, and third line drug is GnRH. If GnRH is also unable to relieve the pain, then you are going to go for laparoscopy, right? Now, if your patient of endometriosis comes to you with moderate to severe pain, then you begin with GnRH, and if GnRH is not relieving the pain, then you are going to do laparoscopy, right? A patient of endometriosis can come to you with infertility. If infertility is minimal or mild, so if there is minimal or mild endometriosis and that is leading to infertility, you have to manage it like unexplained infertility. And management of unexplained infertility is clomiphene citrate plus IUI. If infertility is due to moderate to severe endometriosis, then you have to go for IVF, right? Now, coming to endometrioid or chocolate cyst. As I told you, endometriosis ka patient can also present to you with adnexal mass. Adnexal mass is nothing but a chocolate cyst. Now, if a patient of chocolate cyst is desiring pregnancy, just tell her, I am not going to do anything. First, complete your pregnancy, complete your family, and then I'm going to manage it. So you have to just follow it up with ultrasound. Now, if a patient does not desire pregnancy, a patient of chocolate cyst does not desire pregnancy, and the chocolate cyst is asymptomatic and its size is less than 5 centimeters. Asymptomatic and size less than 5 centimeters, again no treatment. But if it is symptomatic or if its size is more than 5 centimeters, either it has to be symptomatic or its size has to be more than 5 centimeters, then I am going to do laparoscopic cystectomy. That is how you manage patients of endometriosis. I'm sure all of you know that what is the most common site for endometriosis? Most common site for endometriosis is ovary followed by pouch of Douglas, right? What is the most common theory which explains endometriosis? The most common theory which explains endometriosis is theory of retrograde menstruation or theory of implantation, which was given by Sampson. What is the investigation of choice in endometriosis? It is laparoscopy. And what is the gold standard investigation in endometriosis? It is histopathological examination. Whenever a patient of endometriosis comes, she's going to come to me with dysmenorrhea. Because she's going to come to me with dysmenorrhea, what is the first investigation I am going to do? The first investigation which I am going to do in her will be ultrasound. And on ultrasound, I am going to see the chocolate cyst. How does a chocolate cyst appear on ultrasound? A chocolate cyst is going to have a ground glass appearance, or this is called as a cyst with homogeneous internal echoes. It is not jet black, it has a ground glass appearance, or it is a cyst with homogeneous internal echoes. Chocolate cyst is always bilateral. When you are going to do a laparoscopy in a patient of endometriosis, you can again see the chocolate cyst, or you can see these red lesions, right? These red lesions, they indicate the newly formed lesions in endometriosis. Or you can get these blackish colored lesions which are called as the gunshot appearance or the powder burn appearance, right? Or you can get these peritoneal defects which are called as Allen-Masters syndrome. Clear to all of you? These are the appearances which you get in endometriosis on laparoscopy. Yes, Okay, management of endometriosis, I've already told you. Now, coming to adenomyosis. In adenomyosis, endometriosis ki patient complains to you of dysmenorrhea or pain. That's her most common complaint. Adenomyosis means when endometrium is present inside the myometrium. Right? And patient most commonly complains to you of menorrhagia plus dysmenorrhea. Patient will have menorrhagia and dysmenorrhea. Age of the patient will be more than 40 years and she will be multiparous. In endometriosis, patients are nulliparous because it is an estrogen dependent condition and they are reproductive age females. Right? The investigation of choice in adenomyosis is MRI. And the gold standard investigation is histopathological examination, which you are going to do after you perform hysterectomy. Management of adenomyosis is total abdominal hysterectomy. Now, in adenomyosis, please understand, in adenomyosis, the endometrium is present inside the myometrium. When endometrium is present inside the myometrium, myometrium is going to undergo hyperplasia, and that is why you are going to get a globular uniformly enlarged uterus. So whenever you are getting a globular uniformly enlarged uterus, and the size of the uterus will always be less than 12 weeks pregnant uterus size. It will never be more than 12 weeks pregnant uterus size. So uniformly enlarged globular uterus is a finding which you get in adenomyosis. In adenomyosis, uterus is tender to touch. That is what is called as Halban sign. And the size of the uterus will always be less than 12 weeks pregnant uterus size. Right? When you are going to see a cut section of the adenomyotic uterus, you will see that there are multiple hemorrhages which are present inside the myometrium, which indicates that menstruation has happened in the endometrium, which is present inside the myometrium. Right? On ultrasound, in adenomyosis, you can get a myometrial cyst, that which indicates blood inside myometrium. Myometrial cyst is the most specific finding on ultrasound in case of adenomyosis. Or you can get alternate dark and light bands, which is called as Venetian blind appearance. Right? So, ultrasound appearance mein you can get a myometrial cyst, which is the most specific, and you can get Venetian blind appearance, which is alternate dark and light bands. Right? Now, when it comes to polyp, a patient of polyp will complain of bleeding. This bleeding is going to be irregular bleeding. Now, polyp can be seen in any age. Please remember, polyp is the most common cause of postmenopausal bleeding. The investigation of choice for polyp is hysteroscopy. Right. Now, in polyp, you have to remember that a polyp is supplied by a single blood vessel. A polyp is supplied by a single blood vessel. Right. This is called as feeder vessel. Right, and this on ultrasound is going to give you a feeder vessel sign. So I have given you a feeder vessel sign also over here. This, see over here. On ultrasound, you are seeing a single blood vessel coming up till the center. That is the feeder vessel sign. Right? Now, in case of polyp, you are going to get a red homogeneous small mass which will hang inside the uterus. Whereas in case of fibroid, you are going to get a tan color mass which is arising from the uterus. It will have a broad base. Right? Whereas polyp will always have a narrow base. Right? Polyp is red fleshy mass, whereas a fibroid is white in color and it has a whorled appearance. Please remember, a fibroid is surrounded by a pseudocapsule, and the blood vessels which supply the fibroid, they are present in pseudocapsule. Right? So when you are going to switch on the Doppler in case of fibroid, so if this is the fibroid and this over here is pseudocapsule, when you are going to switch on the Doppler, you are going to get blood vessels which are present around the fibroid. Right? You are going to get blood vessels which are present around the fibroid. Whereas in case of polyp, you are going to get feeder vessel sign. Right? A single blood vessel in a polyp is going to come inside the polyp. Right? That is what is a feeder vessel sign. Very, very important. Many times this question has been asked in your exam as a spotter. Right? So these were the appearances of fibroid and polyp. How do you manage a polyp? Now, for management of polyp, please remember, a polyp can be endocervical polyp or an endometrial polyp. Endocervical polyp ka management is a polypectomy using a polyp hook. Whereas endometrial polyp ke liye you need to go for hysteroscopic polypectomy. Right? Then you need to know the management of Bartholin cyst. Where is a Bartholin cyst present? A Bartholin cyst is present between labia majora and labia minora at the junction of anterior 2/3 and posterior 1/3. Right? So whenever you get a cyst which is present between labia majora and minora at the junction of anterior 2/3 and posterior 1/3, that means you are dealing with Bartholin cyst. Bartholin glands are also called as greater vestibular glands, and Bartholin gland is homologous to which gland? Bartholin gland is homologous to Cowper's gland in males. Cowper's gland is also called as bulbourethral glands. Skene glands are homologous to prostate glands in males. Right? Then, what is the management of Bartholin cyst? If Bartholin cyst is asymptomatic and if it is less than 3 centimeters in size, no management required. If it is asymptomatic and more than 3 centimeters in size, then you have to go for incision and drainage. And after incision and drainage, you have to place a word catheter. Right? If it is a Bartholin abscess, again incision and drainage. If it is recurrent Bartholin cyst, then the management is marsupialization. Please do not say that the management of Bartholin cyst is marsupialization. That's an outdated answer. Now the answer is incision and drainage. So over here I have a finding per vaginal examination finding comparing fibroid, polyp and adenomyosis. Very, very important, because in your exam sometimes they don't give you the diagnosis. Based on examination findings, you have to make a diagnosis. In case of fibroid, on per vaginal examination, uterus will be enlarged. And how much enlarged? It can be enlarged up till 20 weeks pregnant uterus size. Right? And because fibroid arises from one side, so the uterus is going to be irregular and it is going to be non-tender. You won't get any finding in adenexa. In case of polyp, it's a chotu sa mass which is inside the uterus. So uterus is normal in size, anteverted. In case of adenomyosis, the size of the uterus is 10 to 12 weeks pregnant uterus size. Then uterus is uniformly enlarged. Uterus is uniformly enlarged and uterine tenderness is present, which is called as Halban sign. Now, sometimes adenexal tenderness may be present, but there is no adenexal mass in case of adenomyosis. Right? In endometriosis, Dr. Jain, we generally don't remove the uterus. But suppose if dysmenorrhea is not getting relieved, I have done everything but dysmenorrhea is not getting relieved, then the last resort becomes hysterectomy. Hysterectomy is only going to solve one purpose. Hysterectomy means that now there won't be any retrograde menstruation, and because there won't be any retrograde menstruation, no new lesions will be formed. So pain कम नहीं होगा लेकिन pain बढ़ेगा भी नहीं. Right? The disease is not going to progress, but the disease is not going to regress also. So the last resort is hysterectomy. In adenomyosis, the management of choice is hysterectomy because endometrium is present inside the myometrium. Right? Okay. Now, in case of endometriosis, per vaginal findings are very, very important. In case of endometriosis, you get a fixed retroverted uterus. Whenever your question says fixed retroverted uterus, it means it is endometriosis. Please remember, retroverted uterus can be seen in prolapse and it can be seen in endometriosis. In prolapse, it can be corrected manually, so it is not called as fixed. In endometriosis, it cannot be corrected manually, and that is why you call it as fixed. Now, in case of endometriosis, in adenexa, you are going to get bilateral adenexal mass, that is chocolate cyst. So, these are the per vaginal examination findings which you have to remember. Now, the distension media used in hysteroscopy in bipolar cautery is. Now please remember, hysteroscopy pe there are just few important points which you have to remember. Now in hysteroscopy, always I have to use a distension media. This distension media can be carbon dioxide or it can be a liquid based media. Carbon dioxide is used only for diagnostic purpose, but if you are using liquid based media, then it can be either electrolyte rich media or electrolyte deficient media. Electrolyte rich media is normal saline or ringer lactate, and electrolyte deficient media is 1% glycine, mannitol or sorbitol. Right? Now, what is the difference when I use electrolyte rich media and electrolyte deficient media? Electrolyte rich media can be used only with bipolar cautery, whereas electrolyte deficient media can be used both with monopolar and bipolar instruments. That's one difference. Second difference, please understand, when I am using a liquid based media, that means I am putting normal saline inside the uterus. I will keep a person who's going to watch that how much liquid went inside and how much came outside. For example, if I have given 1000 ml of normal saline to the patient, in channel say 1000 ml, and out channel say it is only 500 of normal saline which has come out, this means the remaining 500 ml has been absorbed by the patient's body. This is what is called as fluid deficit. Fluid deficit means the amount of fluid which is given minus the amount of fluid which comes out, which is equal to the amount of fluid which has been absorbed by patient's body. Right? The best part about electrolyte rich media is that even if a patient body absorbs sufficient amount of electrolyte rich media, still I am not worried about water intoxication. Water intoxication does not happen with electrolyte rich media, and that is why I am going to stop the procedure only if the patient's body has absorbed 2.5 liters of the fluid. So electrolyte rich media may you have to stop the procedure when fluid deficit is 2.5 liters. But in case of electrolyte deficient media, water intoxication can happen, and that is why I have to stop the procedure when the fluid deficit is 1 liter. Electrolyte deficient media can lead to water intoxication, and it can also lead to hyponatremia, right? So now your question was, with bipolar cautery, which distension media can be used? With bipolar cautery, you can use both electrolyte rich and electrolyte deficient media. That means you can use normal saline also, and you can use glycine also. Both of them can be used, right? Okay. Then, Neet PG 2019, treatment of choice for a postmenopausal female complaining of vaginal itching and having atrophic vaginitis. That means your patient is having atrophic vaginitis, means senile vaginitis, and atrophic vaginitis these days is also called as genitourinary syndrome of postmenopausal female. Now, this atrophic vaginitis is happening because of decreased estrogen. When estrogen is decreased, lubrication is decreased because estrogen is the one which leads to increase in cervical mucus. So whenever there is atrophic vaginitis, the first drug of choice is I have to give lubricants. Second drug of choice is I have to give topical estrogens. And the third drug of choice is ospemifene, right? Ospemifene. Now, please understand that I made you write this earlier also, that all SERMs, they lead to vaginal dryness like clomiphene, tamoxifen, and raloxifene except ospemifene. Now, in this question, the option given to you was clomiphene, topical estrogen, OCP is an antihistaminic. My answer has to be topical estrogen, right? Then, next question, which was Neet 2021 question. A 28-year-old married woman was anxious to conceive. She presents with copious vaginal discharge without itching. She had her period 13 days back. What is the cause of discharge? Now, whenever there is discharge without itching, that means either it can be physiological or it can be bacterial vaginosis. In bacterial vaginosis, the discharge is dirty white in color. There is no itching, but it will have a foul smell. In case of physiological discharge, which is leukorrhea, there are three characteristics. It is white in color. Again, there is no itching and there is no foul smell. Now, because they are saying that the periods happened 13 days back, that means it is mid-cycle. Mid-cycle may the discharge is going to be very much in case of leukorrhea. I am going for leukorrhea because of two reasons. Because the question did not mention anything about foul smell, and because it is saying the discharge is copious and they are specifically telling me that her periods happened 13 days back. That means this discharge is because of leukorrhea. Right? Now, coming to important points on vaginitis, very, very important for your NEET PG. First of all, depending on the color, you have to make a diagnosis. If your question is saying frothy discharge, yellowish green in color, that means it is trichomonas vaginitis. If your question says curdy white discharge or cottage cheese like discharge, that means it is candidiasis. If your question says dirty white discharge, bacterial vaginosis, white discharge, leukorrhea. Right? If your question is saying foul smell, then it could be bacterial vaginosis, it could be trichomonas, or it could be candida. If itching is the main symptom, if the patient is coming mainly because of itching, then it is candidiasis, second most common cause, trichomonas. Right? But if there is no itching, then either it has to be bacterial vaginosis or leukorrhea. pH of the discharge. In every other case, pH is more than 4.5, whether it is bacterial vaginosis, whether it is trichomonas, whether it is leukorrhea. Only one organism can survive in acidic media, and that is candida. So if pH of the discharge is acidic, it has to be candidiasis. Right? Now, if your question is saying whiff test positive, whiff test is positive in bacterial vaginosis. Sometimes it is also positive in trichomonas, but most of the times whiff test positive means bacterial vaginosis. Clue cell seen, again bacterial vaginosis. Strawberry vagina, trichomonas. Splash dysuria, candida. Right? Then comes syndromic management of discharge. Now, for syndromic management of discharge, we use kit number 2. This kit number 2 is a green colored kit which has secnidazole and fluconazole. Fluconazole is going to take care of candidal infection, and secnidazole is going to take care of bacterial vaginosis and trichomonas. Although the drug of choice for bacterial vaginosis and trichomonas is metronidazole, but kit number 2 does not have metronidazole, it has secnidazole. When you are giving kit number 2, partner treatment is not required. When you are specifically treating trichomonas, for specific management of trichomonas where the drug of choice is metronidazole, partner treatment is required. But if it is kit number 2 which you are giving for vaginal discharge, partner treatment is not required. Right? Now, let's look at this question. A sexually active female with profuse frothy, the word frothy tells me trichomonas, foul smelling discharge, intense itching, strawberry cervix. All these point towards what? All these point towards trichomonas vaginitis. Clear to all of you? Right? Now, done? Till here, have you all done? Okay. Now, please understand, how am I going to decide which kit has to be given to the patient? How am I going to decide? How am I going to decide which kit has to be given to the patient? If your question is talking only about discharge, if it is just vaginal discharge, then I have to give kit number 2. But if your question says discharge and your question says that on per speculum examination, cervical erosion or cervical lesion was present, that means it is a case of cervical discharge. That means it is not a case for vaginal discharge, and then you have to give kit number 1. The color of kit is grey colored kit. Kit number 1, it has got tablet azithromycin. How much azithromycin? 1 gram. Right? And it has got tablet cefixime. How much cefixime? 400 milligrams. Single tablet of azithromycin, single tablet of cefixime. Right? Now, if your question says that there is discharge plus there is pain in abdomen and any one of the following, cervical movement tenderness, adnexal tenderness or uterine tenderness, अभी भी पेशेंट डिस्चार्ज की कंप्लेन लेकर आ रही है, बट अलॉन्ग विद डिस्चार्ज देर इज पेन इन abdomen and there is any one of the following: cervical movement tenderness, adnexal tenderness or uterine tenderness. That means I have to now give her kit number 6, that is yellow kit, which is for PID. Right? Clear to all of you? Yes? Now, next is some important next steps which I want you to know. Till here, have you understood? Just give me 2 minutes. I want to drink water. I'll just have water and come. Give me 2 minutes. Right. Okay. Some important next steps which I want you to know. So whenever your question says a female has come to you with atypical uterine bleeding and they say she's a reproductive age female, you are going to do UPT and you are going to do TVS. Right? This is the investigation which you have to do whenever a female comes to you with AUB in reproductive age group. Now, if your patient continues to bleed despite treatment, or if she has high risk of endometrial cancer, or if endometrial thickness is more than 11 millimeters, then only I have to do endometrial biopsy. Not in every reproductive age female who comes to me with AUB, I don't do endometrial biopsy. Only if endometrial thickness is more than 11 millimeters, or if she has high risk for endometrial cancer, or if she continues to bleed despite treatment, then I do endometrial biopsy. On the other hand, If she is a perimenopausal female, that means a female who is more than 40 years according to Indian standards and more than 45 years according to international standards, I have to do UPT, I have to do TBS, and I have to do endometrial biopsy. Irrespective of TBS findings, I have to do endometrial biopsy. Irrespective of TBS finding. यहाँ पे they try to confuse you. They try to say, question comes that there is a female who is 42 years of age who came to you with excessive bleeding. You got an ultrasound done. On ultrasound, you got fibroid. What is the next step? Now, because they say on ultrasound there is fibroid, you start thinking about managing a fibroid. You forget that irrespective of ultrasound finding, I have to do endometrial biopsy. So your next step is endometrial biopsy. Don't say I will manage fibroid. Clear to all of you? Okay. Now, when it is a postmenopausal female, obviously I don't have to do a UPT. I will do her TVS. And on TVS, if endometrial thickness is less than 4 millimeters, endometrial biopsy not needed. If endometrial thickness is more than equal to 4 millimeters, endometrial biopsy needed. Right? Okay. Now, case number 2. A patient comes to you with post-coital bleeding. Now they ask you what is the next step. Whenever a patient comes to you with post-coital bleeding, next step is per speculum examination. On per speculum examination, if everything is normal, then you do a pap smear. Right? On per speculum examination, if a growth is seen, you are going to do punch biopsy. On per speculum examination, if the question says that there is thick cervix, or question says there is barrel-shaped cervix, or question says there is indurated cervix, then you are going to go for what? Tell me. Then you are going to go for colposcopy. Clear? So these are important next steps. Then, now important next step is a couple has come to you with complaint of infertility. Very, very important is the definition of infertility. What is infertility? Infertility is inability to conceive even after 1 year of unprotected intercourse. Only if the age of the patient is more than equal to 35 years, then the investigation should begin 6 months after unprotected intercourse, right? Usually, the investigations for infertility are going to begin after 1 year of unprotected intercourse. Only if the age of your female patient is more than 35 years, then the investigations for infertility should begin at 6 months after unprotected intercourse. Now, what are the basic investigations which you are going to do whenever a couple come to you with infertility? Basic investigations are semen analysis, test for ovulation. In test for ovulation, I will do serum progesterone levels and HSG. These are the 3 basic investigations which I have to do in all patients who are coming to you with infertility. Now, if your question says that there is semen analysis was done and semen analysis of the husband shows azoospermia, what is the next step? Now, if semen analysis shows me azoospermia, my next step is I have to do a repeat semen analysis. This repeat semen analysis ideally should be done after 1 month. Ideally, it should be done after 1 month, or at least it should be done after 1 week. Now, on repeat semen analysis, if still I am getting azoospermia, then I have to follow it up with FSH, LH and testosterone levels. Right? Out of all these 3, the most important is FSH levels. If FSH levels are decreased, that means the problem is in hypothalamus or pituitary. If FSH levels are increased, that means the problem is in testes, like it can be Klinefelter's syndrome. Here the problem could be Kallmann syndrome, right? Or it could be increased prolactin. If FSH levels are normal, that means it is a case of obstructive azoospermia, right? It is a case of obstructive azoospermia. Obstructive azoospermia means that there is some obstruction in the passage. Some obstruction in the passage of sperms. Sperms are being produced normally, but there is some obstruction in the passage of sperms. Now your question very recently came that it is a case of obstructive azoospermia. FSH levels are normal, right? Now if FSH levels are normal and if your question says fructose is present and semen volume is normal. If your question says it is a case of obstructive azoospermia with fructose present and volume of semen normal, that means the lesion is above seminal vesicles. That means the lesion is either in epididymis or the lesion is in vas deferens. The problem is in epididymis or the obstruction is in vas deferens. And in order to know where is the obstruction, I am going to do a scrotal ultrasound. So whenever you are getting obstructive azoospermia and your question says fructose is present, volume of semen is normal, right? That means the problem is above the level of seminal vesicles. That means the problem is in epididymis or vas deferens. And in order to know what is the problem, I am going to do scrotal ultrasound, right? Now, if your question says fructose levels are absent and semen volume decreased, fructose absent, semen volume decreased means there can be three cases, and for that first I have to do rectal ultrasound. I will do a rectal transrectal ultrasound. Transrectal ultrasound. Now when I am doing a transrectal ultrasound, if I see seminal vesicles absent, please understand, major contributor of semen is seminal vesicle. So अगर semen volume decreased आ रहा है, if semen volume is decreased, either the problem is that seminal vesicles are absent, that is why semen volume is decreased. Seminal vesicles are absent in cystic fibrosis. In cystic fibrosis, there is bilateral congenital absence of seminal vesicles and vas deferens, right? Or it could mean that there is a block below the level of seminal vesicles. A block below the level of seminal vesicle means the block is in ejaculatory duct. So you tell me this is ejaculatory duct, these are seminal vesicles. Now, if a block is in ejaculatory duct and seminal vesicle is unable to give its secretions, what should I expect the seminal vesicles on ultrasound? I should expect that the seminal vesicles should be present and they should be dilated. So, if on ultrasound I am getting seminal vesicles dilated, seminal vesicles are present and dilated, that means the problem is in ejaculatory duct. There is obstruction in ejaculatory duct. Now, if I see on transrectal ultrasound seminal vesicles present hai, but they are not dilated, then that means it is retrograde ejaculation. Right? So, whenever fructose is absent, seminal vesicle का जो fluid होता है, it is rich in fructose. So whenever your question says fructose absent or your question says semen volume less, it means seminal vesicles have not given its secretion or its contribution to semen. And why has seminal vesicle not given its contribution? Because either seminal vesicles are absent. If seminal vesicles are absent, that is cystic fibrosis. Or it could mean that there is an obstruction in ejaculatory duct because of which whatever fluid was present in seminal vesicle is unable to come out. right? In that case, seminal vesicles will be dilated. Seminal vesicles will be present on transrectal ultrasound, but they will be dilated. Or if I am getting seminal vesicles present भी है लेकिन dilated भी नहीं है, that means it is retrograde ejaculation, right? Now, next question. What is the minimum sperm concentration which is required for IUI? 10 million per ml. What is the minimum sperm concentration required for IVF? 5 million per ml. What is the most important parameter on semen analysis? Most important parameter on semen analysis is sperm morphology. After sperm morphology, it is sperm motility. That is the second most important parameter. Third most important parameter is sperm concentration, right? Now, important things which you have to remember on semen analysis. These are the recent semen analysis parameters which came in 2020. Please remember, these semen analysis parameters are not telling you average values. They are telling you minimum values which are required for conception. So, volume of semen 1.4 ml, pH 7.2, concentration 16 million per ml, morphology at least 4% sperms should be normal. This is as per strict Tigerberg criteria. Motility, total motility 42%, progressive motility 30%, viability 54%, and total sperm count 39 million per ejaculate. These semen analysis parameters you have to remember. Now, what is the management of severe oligospermia, asthenospermia? Management of severe oligospermia. Severe oligospermia means sperm concentration less than 5 million per ml. As I told you, minimum sperm count required for IVF is 5 million. So, in severe oligospermia, I cannot use IVF, right? In severe oligospermia or in asthenospermia, I will use ICSI, intracytoplasmic sperm injection. What is the management of unexplained infertility? IUI plus clomiphene citrate, right? Okay. Now, coming to certain spotters. Identify the image. This was given in Neet PG 2020. Is it a normal HSG? Is it bilateral hydrosalpinx, bilateral cornual block, or none? Please remember, over here you are getting dilated tubes. Dilated tubes का मतलब है that this is bilateral distal block. This is a bilateral distal block, right, which has led to hydrosalpinx, right? So the answer over here is bilateral hydrosalpinx, right? Now, whenever there is bilateral hydrosalpinx and they ask you what is the next step, please remember, for tubal patency, the investigation of choice is HSG, but the gold standard is laparoscopic chromopertubation. So whenever I am getting a block on HSG, my next step has to be to do a laparoscopic chromopertubation to follow it up, right? So my next step is laparoscopic chromopertubation. Next time they may show you this HSG and they may not ask you the diagnosis. They may ask you that what is the next step? Next step is laparoscopic chromopertubation. What is the management of a distal block? Whenever there is a distal block, right, you have to do IVF. You have to do IVF if it is a severe distal block. Now please understand, ये जो hydrosalpinx का fluid होता है, this is embryotoxic, right? So when I do IVF, this fluid can come inside the uterus and kill the embryo. That is why before I do IVF, I should either remove the tubes, as it is the tubes are not solving any purpose. So I will do bilateral salpingectomy followed by IVF. Or what I can do is I can put a clip over here, right? I can apply a clip and then I can go for IVF. So if they show you this HSG and they ask you what is the next step is laparoscopic chromoperturbation. And if they ask you what is the management is bilateral salpingectomy followed by IVF or clipping followed by IVF. Now, they may show you this this HSG. In this HSG, what you are seeing? In this HSG, you are seeing the dye has gone up till the cornual end, right? And now there is no further spillage of the dye. That means it's a bilateral cornual block. What is the most common cause of a bilateral cornual block? Bilateral cornual block, most common cause is physiological spasm. What is the most common pathological cause? Most common pathological cause is genital TB, right? Most common pathological cause is genital TB. Whenever they give you this HSG and they ask you what is the next step, as I told you, जब भी block होगा, my next step is laparoscopic chromoperturbation. But whenever there is a cornual block, because it could be physiological, so I will do a laparoscopic chromoperturbation, but along with that, I will do hysteroscopic cannulation. What do you mean by hysteroscopic cannulation? I will take a guide wire under hysteroscope guidance and I will pass the guide wire so that the spasm is relieved, and then I will do laparoscopic chromoperturbation. So I am going to do hysteroscopic cannulation plus laparoscopic perturbation. Many a times the block is relieved by this step. If the block is not relieved by this step, that means it is due to genital TB, and then the best management is IVF. So if they ask you next step is hysteroscopic cannulation and laparoscopic chromoperturbation. If they ask you the best management is IVF. Clear to all of you? Now, after this, what is left is images related to ovarian cancer. Everything related to ovarian cancer and its images I have included in the PDF which I have given to you. So I'm pretty sure you will be able to do this now yourself. This completes the detailed discussion which I had to do with you on gynae revision. As far as your obs revision is concerned, beta, I have my set of recordings which I have to do for super speciality, and I have my class coming up in Bangalore. That is why I will not be able to take your obs revision because I am leaving for Bangalore tomorrow morning, right? So you can see for obs revision, I think you can do it yourself. If not, then there are previous obs revision videos which are there on my YouTube channel. So you can look at all those videos on the previous obs revision. That is चलो PYQs करें. जो चलो PYQs करें of NEET PG 2023 था, उसमें majority of obs I have covered. There I had given less importance to gynae. That is why this time I have taken up gynae revision with you. Obs revision you can do from the previous videos, right? So all the best for your exam. Keep studying, and if you have any queries, you can ask me on the CTG group. Right? All the best. Take care. Love you all. I hope you people are going to make maximum use of this gynae revision video, and you are going to watch the obs revision from Chalo PYQs Kare. Right? Take care. Bye-bye.